Good morning, everyone. Welcome to the symposium. I want to give a special welcome to folks we have in an overflow room just across the hall from the room we're currently in, and to people on the web. We've got about well over 60 people on the webinar that are going to be streaming into this meeting. My name is Jeff Capobianco. I'm with the National Council for Behavioral Health, and I'll be helping facilitate the symposium today. Very excited to have you all here. Simply by the number of people that have registered and taking part in this really underscores the importance of what we're doing here today to really begin to tell a new story about how we can better meet the needs of families and children who are experiencing attention deficit hyperactivity disorder. Today we're going to have a very busy agenda, so we're going to ask the people hold their questions. We've got some very informative speakers. You might want to ask a question, and you certainly can. We just ask that you do it in the form of writing it on the web chat to the right of your screen, if you're on the web. Or if you're here at the meeting with us, there are cards in your packet. You can write your questions on those cards, and there's also an evaluation where you can write your questions down. Certainly at the break times and in our afternoon breakout sessions, there will also be additional times for people to ask questions. Some housekeeping notes. If you're in the building, the bathrooms are just outside the lobby to the left or right. So if you go to the lobby, if you're coming from the overflow room, it'll be on your right. If you're coming from this room, it'll be on the left. We will be breaking at noon for lunch for 1 hour, and we will start promptly at 1 o'clock after lunch. If you have been here for parking, if you have parking, please make sure you validate those tickets with the reception area. There's a lot of material to cover here today, so make sure you look through your packet. Each of you are responsible for doing some of the work we're going to be doing today. This is actually a working meeting. So we ask that you take a look at the agenda, and you'll see that there's 3 themes that really play out today as we talk about this very important topic. And there are, how can we improve the assessment, how can we improve the treatment, and how can we improve the support to families and children who are experiencing these conditions. We would like each of you, because you have your own story, your own experience with this topic area, to think about how, in your experience and based on what you learned today from the topic speakers, how could this be improved? How could you be a part in the improvement? How do you see others being a part in the improvement? And in the afternoon during the breakout sessions, we're actually going to really dig into that topic area, looking at how we can improve things and identifying solutions to move forward. Other than that, I just want to, again, welcome everyone. Thank you for coming, and would like to introduce Secretary Kathy Kleber from the Health and Hospitals of Louisiana, who's going to give a brief introduction.
Good morning. I'm Kathy Kleber, the Secretary of the Department of Health and Hospitals. I'm glad everyone is here today, and as was said, by the interest that we've had for this symposium, clearly this is a topic that we all have invested a lot in either in the past or recognize what it means for our future of our children in Louisiana. We know some of the stats, and we're y'all going to hear more about the stats today about both in Louisiana and nationally and what that means. But I appreciate everybody's attendance here. We've got a lot of leaders here today, champions from all different areas of medicine, behavioral health, health plan management, education, family members, advocates, and government. I hope the end goal today is to develop solutions to address the proper utilization of ADHD medication in Louisiana's children. First, I'd like to take a minute to thank both Senator David Heitmeyer and Representative Scott Simon. They both worked really hard on a resolution in the spring legislative session. I'd also like to thank our panelists and members of our ADHD task force that was developed. And I'd especially like to thank Dr. Kristen Savecki and Heather Taylor. Where's Heather? Oh, in the back over there. They're the 2 people that worked so hard to pull all this together, to get all the logistics, to make sure we had good panelists, to make sure that we had good space as well as good information that we'd be sharing today. So thank you both for all your hard work so far, and we still have more work to do. This past spring, the nation's largest prescription drug manager, Express Scripts, issued a report with some disturbing facts about the use of ADHD medications in Louisiana. Louisiana had the second highest proportion of residents on an ADHD medication in the country, at 4.7% for the population as a whole, and an alarming 13.6% for boys aged 12 to 18. Louisiana also has the highest number of older girls and young women on ADHD treatments. In 2012, 7.8% of girls aged 12 to 18 were on ADHD drugs, while 8% of 19 to 25-year-olds were taking these medications, nearly double the number of females their age undergoing similar medication treatment nationwide. So in response, the legislature passed Senate Concurrent Resolution 39, sponsored by Senator Heitmeyer, calling on our department, the Department of Health and Hospitals in Louisiana, to study how the state can ensure the proper utilization of ADHD medications in Louisiana. We quickly assembled an internal task force to study the issue with representatives from Medicaid, the Office of Behavioral Health, the Office of Citizens with Developmental Disabilities, and the Office of Public Health. This task force looked at state and local data, some of which you'll hear about today. And, you know, our data, as the Express Scripts data, showed some very troubling trends. So, for example, according to our own data, 14.2% of 5-year-olds on Medicaid in Louisiana born in September and born in the month of September are on ADHD medication. Only 6.1% of 5-year-olds born in October are on ADHD medication. So almost over double the amount, 2 different months. Does that mean that we have a lot more kids in September that have a clear diagnosis of ADHD? Of course not. It just means that those are the youngest kids in our classes. They're seen as developmentally immature, and so nearly twice as likely to be Medicaid. That's a really scary statistic when you think about it, because as I said, you know it's not the fact that somebody born in September is any more likely to have an ADHD diagnosis than somebody in any other month. So clearly there are some things that we have to look at in both the assessment and diagnosis and treatment of those children. Dr. Susan Visser from the CDC will also share with us the national data and possible solutions other states have implemented to ensure the proper treatment for children diagnosed with ADHD. We'll also hear from a panel of Louisiana experts on innovative efforts taking place in our own state to find solutions for our state's high rates of this ADHD medication utilization. Lastly, and most importantly, we want to hear from you. We'll have breakout sessions near the end of the day so we can gather your input and expertise. From our work today, we will develop a report to the state legislature outlining possible action that can be taken by our state to deal with this issue. We also want to be able to inform you so you can share with your friends and communities what they can do to make sure that ADHD medications are utilized correctly. I'm going to go off my script and talk as a mom. You know, as a mom, none of us want our kids to be on medications at all. Certainly not an ADHD medication that we don't know we don't really know what long-term effects these medications are going to have on these kids 20, 30 years from now. I mean, these medications are fairly new. We have some research which is already disturbing in terms of long-term effects. We certainly don't know what's going to happen in the future with long-term effects. But also as a mom, I want a child, when I raised my 3 kids, one of whom was extremely hyperactive, I wanted my child to be successful in school, to be successful in a career, to be able to have friends and be happy in her social life. However, kids with ADHD experience problems in all of those areas. So our goal today can't simply be that we want to reduce the number of kids on ADHD medication. Our goal has to be that we want viable alternatives for families, for parents, for providers, for pediatricians that are faced with these issues, our educators. We have to have viable alternatives for them because, again, I think what everybody wants is those kids to be successful And certainly as a parent, we want alternatives, other options that we have. So I ask you today to be innovative. Think of things that are alternative medications for these kids. Work with us to figure out what a truly good assessment and treatment process looks like. Help us, give us feedback on what options we need to have in the future in Louisiana for treatment and alternatives to just medication. So please, again, as was said earlier, this is really a working group. Please give us your feedback. Give us your thoughts. There's lots of inventive things going on throughout the state. One of my favorite things is what went on in Finland with kids in schools doing a 45-minute instruction time, 15 minutes free play every hour, every single hour during the day. Wouldn't that be great if we could get some schools here that were willing to try that? So be innovative, be creative about things that we can do differently in this state to offer alternatives to those families. Thank you again for being here. Appreciate all of your time and attendance.
Thank you, Secretary. Up next, we have Dr. Susan Visser, who is from the Center for Disease Control in Atlanta. She's the acting Associate Director of Science in the Division of Human Development and Disability in the National Center for Birth Defects and Disabilities. She comes to us as an expert in attention deficit hyperactivity disorder, and as the Secretary had mentioned, what we'd like for you to do as the audience today and as stakeholders in this process is to really be thinking about what she presents to us and what the other experts present to us from the standpoint of ideas that you, as members of this state, as policymakers, as clinicians, as family members, as concerned citizens can do with this information when you get back to your place of work or you get back to your residence. We really want you to think about that, take some notes. We'll be drawing from that this afternoon when we do our breakouts. So without further ado, Dr. Susan Visser, thank you.
And before I get started, can everyone see, is it too bright in the front? Everyone okay? All right. Well, thank you. I really appreciate being here and being part of what I must say is one of the most thorough investigations and evaluations of ADHD treatment that I've seen within any state. And I'm really, really pleased to be part of this. I've been at CDC since 2001. And I'm the lead epidemiologist of the Child Development Studies team there at the National Center on Birth Defects and Developmental Disabilities, which is where we house our developmental disability work, autism, ADHD, Tourette syndrome, really trying to understand the epidemiology or the pattern of expression of these disorders, as well as trying to understand how do we improve quality of care for children who have these disorders, and also improve family outcomes and impacts. And I am an epidemiologist. I'm a doctor in public health. I'm a mother of 3 and a wife, a friend and referral source for any one of my friends or colleagues who have a child with ADHD. I'm not a medical doctor, however, and I want to make sure that that's clear. I was the committee epidemiologist for the American Academy of Pediatrics revision, most recent revision of the diagnostic and treatment guidelines. So I'll be talking a lot about that process and about the recommendations from those guidelines. But we have great clinicians here who can speak to some of the clinical aspects if you have questions about those. To begin, we're all here to talk about ADHD, and I think it's important to stay really grounded in the diagnostic criteria. And we know that there are social and environmental and biological components to getting a diagnosis of ADHD. And we start here with the gold standard for diagnostic criteria of ADHD, and it comes from the Diagnostic and Statistical Manual of Mental Disorders. These were revised back in May of 2013, and we had 2 important changes to the diagnostic criteria. We start with symptom counts, symptoms of inattention, hyperactivity, or impulsivity, and you need to have 6 or more to achieve a diagnosis of ADHD as a child. If you're 17 or older, DSM-5 revised the symptom count to require 5 symptoms or more, so dropping it just a little bit for those 17 years of age and older. And then we have what's called presentations, predominantly inattentive, predominantly hyperactive or impulsive, and then the combined subtype where you have both inattentive and hyperactive or impulsive symptoms. I was recently at the National CHAD meeting, which is the primary family advocacy group for ADHD and family support group. And Ben Leahy, who is a fantastic ADHD researcher and involved in developing these criteria over the years, really cursed himself for ever bringing up subtypes at all, because it really implies that once you have a child who's diagnosed with a subtype, that's what they're going to look like for the rest of their lives. The parents in the audience, whether or not you have a child with ADHD, know that behavior changes over time. And so if you have a child who is predominantly hyperactive and impulsive as a young child, you may start to notice over time that the inattentive symptoms start to take hold, and they become actually more impairing than the hyperactive and impulsive symptoms were at one time. So the presentations change over time and need to be revisited. There is an age of onset requirement for symptoms before age 12, and this increased from what used to be age 7 in DSM-IV. And there has to be significant functional impairment, which is really important. It's not enough to just have the symptoms. You can have all 18 symptoms and not have significant functional impairment based on the parent report, for example. So you really have to have impairment. And then also pervasiveness. These symptoms can't occur solely at home or solely at school. You have to see them either with friends and at home or home and at school, that sort of thing. And finally, you have to rule out, as a clinician, other sources of these symptoms. For example, lead poisoning. Lead can cause symptoms of ADHD. Trauma, neglect at home, those can also cause these symptoms, as well as sleep disorders, which is a really important and sometimes difficult to diagnose a set of disorders that can cause these symptoms. Now, we are lucky to have not one but two, at least, sets of practice guidelines from professional academies. One from the American Academy of Pediatrics that was recently revised in 2011 and includes now recommendations by age. We have recommendations for preschoolers, for elementary age kids, and also for adolescents. And it also is accompanied with a process of care algorithm, which was developed really to help primary care physicians walk through the process of diagnosing and treating children in a flowchart form, all the way through to treatment and management or referral or co-management with a specialist. We also have diagnostic and treatment practice parameters, really what they're called, from the American Academy of Child and Adolescent Psychiatry. And these guidelines are really complementary. They are not at odds with each other. There's some information that's been updated based on newer research that we have, but they're very complementary. And here's the process algorithm that I referenced earlier, this flow chart to the right, which I know you can't read, but I just wanted you to see that they really endeavored to try to get this in a do this, then that. Solicit information from these individuals and then proceed on to the next step. And the AAP guidance really recommends starting with an evaluation for ADHD for any child who has ADHD symptoms and also experiences academic or behavioral problems. And they encourage using the DSM criteria that we just spoke about that includes symptoms and impairment in more than one major setting, and strongly recommend that you collect information from parents or guardians, teachers, anyone involved in the child's behavioral health care, school and mental health clinicians, for example. And the clinician should really endeavor to rule out alternative causes, which can be really tricky sometimes, but really trying to do a good job there. And the clinician should also assess comorbidities, because it's more common than not that a child has another co-occurring condition, such as oppositional defiant disorder, conduct problems, a learning disability, anxiety, depression, those sorts of things. And a clinician should also recognize that ADHD is a chronic condition, and it will not likely desist in the next year to two after diagnosis. It's something that will likely persist for 2/3 of children who are diagnosed with ADHD as a child. They will have ADHD symptoms into adulthood. So when this percolates through the medical system and we get to diagnoses of ADHD, this is what it looks like nationally. In 2011 and 12, based on our largest national survey of parents about health and well-being of children nationwide, we collect these interviews via the telephone from 80 to 100,000 families every wave that we do this. And we were conducting the survey every 4 years since 2003, and now it's going into the field for continuous administration starting in 2016, really directed and sponsored by the Maternal Child Health Bureau of HRSA. So we'll get really good annual data moving forward beginning in 2016. But in 2011 and 2012, the most recent data we have is that there are 6.4 million children, school-age children, 4 to 17 years of age, who've received a diagnosis of ADHD. And that's 2 million more than just in 2003, 8 years earlier. There are about 5.1 million with a current ADHD diagnosis and 3.5 million who are taking medication for ADHD. And that's 1 million more than in 2003. Now, this really reflects the national prevalence rates of approximately 11% of children nationwide having ever been diagnosed with ADHD, and that's up from 7.8% 8 years earlier, a 42% increase, or an increase of about 5% per year. And this has really been a linear increase that we've seen for some time now, and I'll show you that in a moment. About 8.8% have a current diagnosis, and more than 1 in 20 kids nationwide are taking medication for ADHD. That should say up from 4.8% in 2007, a 28% increase, and that's about an increase of 7% per year. Okay, so this is a slide that really shows you that whether we go into homes and ask parents about diagnosed prevalence of ADHD, or if we call them on the phone, we're seeing increases of about 3 to 6% per year since the late 90s in diagnosed prevalence of ADHD. And you can see that in another format when we look at what we call a population pyramid. And I'm going to orient you to this slide because the next 3 are going to follow the same format. Boys are on the left, girls are on the right. Age is running up the middle from 4 to 17. And if there's any way to darken the room a little bit, I think this would be a little more successful. Maybe drop a window or something. But what we see is that in the inner bars are the percentage of children who have been diagnosed with ADHD and they're currently taking medication. And the outer bars are the children who've ever been diagnosed with ADHD. So you can see, I hope we don't put people asleep, but that's better. Is that better for people? Okay, that's great. We'll adjust. So you can see that the diagnosed prevalence of ADHD increases into elementary school and then starts to decrease after middle school into high school. And certainly for medication treatment, we see this pattern, this curvilinear pattern where medication increases and then decreases in high school. Now, as we move into 2007 and 2008, the red bars that have been added are the children who have a current diagnosis of ADHD, but they're not currently taking medication. So I'm just going to pivot back and forth, moving from 2003 to 2007. You can see that the absolute size of the pyramid has increased quite substantially, and also the medication bars have really increased independently. And you see that there's this really precipitous increase, particularly for the boys, from 4 to about age 8 and 9, and then more of a stability in terms of diagnosed prevalence. And we're still seeing a little bit of a decrease in medicated ADHD for the older boys. For the girls, it sort of increases and stabilizes. And then moving from 2007 to 2011, again, a really precipitous increase. And what we see is by high school, about 1 in 5 boys have been diagnosed with ADHD by high school, and nearly 1 in 10 girls. And that's nationwide. So when we look at age of diagnosis, we find that the average child is diagnosed with ADHD by age 7, but there's certainly a relationship between age of diagnosis and severity of ADHD. And children with severe ADHD are diagnosed at average by age 5. And this is interesting because it represents not only an opportunity for intervention for our youngest kids, but it also suggests that there may be a phenotype here, where children who have the severest forms of the disorder present very early. These are the children who are kicked out of preschool, sometimes numerous preschools. And really, they need our help to try to address the behavioral problems with the right treatment. And so I hope today will be a day of discussing how to bring the right treatment to especially these young children who present early and then are later described as having severe ADHD. Now, when I talk about phenotype, I'm talking about a group of children who present and they look differently from the other children. And we do know that there are serious biological underpinnings to the diagnosis of ADHD. We do know that there are some social and environmental components to who gets the diagnosis and who gets the medication, but we also know that underlying all of this, in children who have ADHD, they have anatomical differences. And you can see some of them here. For children with ADHD in adolescence, the frontal lobe size and temporal lobe size are smaller than in their non-ADHD peers. And also, there's more gray matter in children with ADHD in their temporal lobes. We also know for the first time, really, that there is a group of children who have what is considered a developmental delay, ADHD as a developmental delay. And we found this through Dr. Philip Shaw's research at the National Institute on Mental Health. And there at NIH, he did multiple brain imaging scans, so MRIs, of more than 200 children with ADHD and more than 200 controls. And they're all, really sort of middle to upper class white children, unfortunately. But their brains shouldn't fundamentally be different. And what they saw was that when they scanned these children from age 10 to until about age 17, they saw that the natural brain growth and then cortical pruning process that happens in adolescence was delayed by 2 to 3 years among children with ADHD. And for some children, that brain growth and cortical pruning process that makes the brain more efficient doesn't happen for everyone, but for a small group of children, a meaningful but and small group of children, they're just delayed. And once they catch up, once that cortical pruning and brain growth process catches up, the symptoms of ADHD desist. They no longer meet criteria for ADHD. So this is an important component of the diagnosis. It definitely does not happen for all children with ADHD, but the authors concluded that some children will outgrow ADHD when their brain development catches up. However, the impairment that they've experienced during this time in early, middle childhood, and even into early adolescence could be felt long-term. And so helping them deal with these impacts is really important. And then for other children, they'll never catch up. And this process either does not happen or happens much, much later. And so we can expect that there are impairments that will remain with these children. So what do we know about the persistence of symptoms over time in children with ADHD? This is a paper that was e-released already, but it'll be in print in January in the Journal of Attention Disorders. And we looked, we took some of our community-based studies that we do in communities across the United States, and we, this is from South Carolina, we looked at the expression of inattentive symptoms over time, and then we also looked at the hyperactive impulsive symptoms over time, and you can see that they track together. And when we collapse them, because they track so well together, we see that children who have inattentive symptoms will continue to have inattentive symptoms. Children who have the hyperactive impulsive symptoms will see a marked decline over time, so that by late adolescence, only about 10% have these hyperactive impulsive symptoms. And I think that's really important for anticipatory guidance for families to understand what to expect, and that the disorder will change, and the symptoms that they're experiencing in their 4, 5, 6, 7-year-old will change over time, but that those inattentive symptoms will continue to challenge the child's executive functioning, their ability to plan and organize, and really control impulses. That really extends from some of these inattentive symptoms, and the executive functioning challenges can be really difficult for achieving in the academic environment, completing high school, going to college. Those things are going to be really, really difficult and require some intervention. So we're going to pull up now to the population level. And I find this really fascinating, and by far the media asks the most questions about these patterns. And I understand why. For ADHD, we see really remarkable patterns in terms of state-based variation for diagnosed and medicated ADHD. And this has always been true since the beginning of 2003 when we started looking at this. There is certainly an east-west gradient where we have much lower prevalence of diagnosed and medicated ADHD in the West. And the states that have the highest rates, however, have been shifting around a little bit, but they remain over to the east. It used to be very heavily concentrated in the south, and now it's a little more distributed. But you can see that the national average for current ADHD is 8.8%. Louisiana finds itself at 13.3%, which is ranked third nationally for children 4 to 17 years of age. When we move on to the percent medicated among those with ADHD, approximately 80% of children in Louisiana who have a current ADHD diagnosis are taking ADHD medication. And that's neither a good nor a bad thing. I have lots of questions people ask me, should that be 100%? Some psychiatrists that I've spoken to have said, that should be 100%. We know medication works, and all our children should be on it. Someone at CHAD actually told me that it's unethical not to intervene with medication, given what we know. It's not that simple. Certainly there is a lot of family choice that goes into this, and also depending on the co-occurring conditions that the child has, you may be much more successful with behavioral intervention. So this is a complicated statistic to interpret. But I do want to say that when you look at the overall rate of medicated ADHD in Louisiana, it's in excess of 10%. 10.4% of children 4 to 17 years of age in Louisiana are taking ADHD medication, which puts Louisiana at the top of the stat in terms of the highest rank for medicated ADHD out of all states. Okay, so we're going to dive in and take a closer look at Louisiana for a moment. If you haven't seen these, I would encourage you, if you're at all interested in state-based estimates, we have a state profile page for each state. And here's Louisiana's. And you can see at the very, very top, we put the state-based estimates since 2003 against the U.S. patterns. And you can see that Louisiana has been outpacing the United States increases for some time now. And then you see the state ranking in the green row there. Louisiana ranked 3rd highest for current prevalence and ranked 1st highest for medicated prevalence. Now, we are able to dig in a little deeper with the National Survey of Children's Health and look at your state estimates against the United States. And these are a simple reminder of what we just talked about, that Louisiana is in excess of the U.S. Estimates for current ADHD and current medication use. But looking within Louisiana, you can see some of these gender patterns and some of the patterns by specific demographic groups. And here you see what is pretty common. We usually see somewhere between a 2 and a 3 to 1 ratio of boys to girls for medicated and diagnosed ADHD. In Louisiana, you're trending a little closer to the 3 to 1 ratio, which I think is really interesting, and we'll talk in a little bit about that. When we look by age, we see that the highest rates are for the 11 to 14-year-olds. I think Ryan's got some really interesting information that gets at a better level of specificity than I can in these grouped age ranges, but I wanted to point this out. And then when we look at these rates of diagnosed ADHD, and current medication use as a function of type of insurance, we see that the lowest rates of current ADHD are among the privately insured children in the state, and that the lowest rates of medication use are, of course, among those who don't have health insurance, which is actually a pretty small number in your state. So looking again by insurance status, Louisiana overall versus Medicaid, you can see that the rates among Medicaid are just a little bit higher than the overall state estimates for ever diagnosed current ADHD and current medication. Nothing really remarkable here. But what I do find interesting is these are gender differences for the United States overall, and you see that really we're at a 2 to 1 ratio nationally of boys to girls, where twice as many boys are diagnosed with ADHD or have a current diagnosis of ADHD, and twice as many are taking medication for ADHD. When we move over to Louisiana, we see that that ratio increases, and more boys proportionately compared to girls are diagnosed with ADHD and are taking medication for ADHD. But then when we move into Medicaid, the gap widens even further. So I think there's something really interesting about likely your boys in poverty in Louisiana that I think warrants further consideration. Now, this is obviously not Louisiana. This is Georgia, my home state. And we looked at some of these estimates as a function of counties. And so we saw a really great variation across states, but we also see great variation across even the county level. And if you look on the right-hand side, what we see in Georgia among adolescents, 11 to 17 years of age, we see as few as 4% of adolescents being medicated in some counties compared to almost 18% in other counties. And the highest rates of medicated ADHD are actually found not in the urban settings, where I certainly hypothesized in that paper that's under review currently, but rather in the rural populations. And I thought, I proposed a theory that perhaps it's because of a lack of access to behavioral services. So briefly, I'm going to talk through what is recommended for treatment. So we talked about how you diagnose a child based on best practices, but how do you treat a child based on best practices? And the American Academy of Pediatrics, in their revised guidelines, as I mentioned, splits it out into 3 groups. And for preschoolers, they really recommend for 4 and 5 years of age, you should use behavioral therapy as first-line treatment. And why do they do that? I sat in and I watched these clinicians really wrestle with trying to provide guidance to clinicians who were being faced with young children who are coming into their offices and looking for assistance with ADHD symptoms and really not knowing what to do with them. And they were doing it on their own. They were making the best decisions they could at the time. And so they wanted to provide guidance. But at the time, there was very little information. We do have the preschool ADHD treatment study, the PAT study, which was a safety and efficacy trial of methylphenidate. And even though short-acting amphetamine, Adderall, short-acting Adderall, is FDA approved for ADHD treatment for children as young as 3, they really felt that there was better evidence around methylphenidate because of the PAT study. And so recommended that if you can find behavioral therapy, if you can get behavioral therapy for these young children, you really need to do that because there are adverse events that are associated with ADHD medication treatment for all children, but especially for young children. I'll talk about that in a moment. If you try behavioral therapy for at least 9 months, you've tried many different things and it's just not working, and you have persistent functional impairment and the child is really in danger to self or others, or you really just need to intervene, then you can try a short course of methylphenidate and very, very carefully titrate it. But they warn that you have to weigh the risks of starting medication at an early age, and we don't have very much information, if any information, about the long-term impacts on preschoolers of these medications, against really the risk of failing to intervene. And we know that there are some very, very serious and important negative outcomes associated with ADHD long-term if left untreated. These include unintentional injury, more motor vehicle crashes, certainly failed academic achievement, lower rates of high school graduation, lower rates of entry into college and completion of college, lower attainment, employment attainment, much more frequent layoffs and termination of jobs. And Biederman and Barbarisi have really interesting data on the costs associated with the societal impact of ADHD among adults, and include really high rates of psychiatric comorbidity as adults and even earlier death. So we're talking about some serious impacts for our kids with ADHD, and so there is really no disagreement from any of the professional academies. Treatment is extremely important, and it's finding the right treatment for these kids and doing it right from the very beginning. So children who are in elementary school, the recommendation is really to try to combine both ADHD medication and behavioral therapy, of course considering the family's preferences. And then for adolescents, there's really not much data out there that suggests that behavioral therapy is going to have a huge impact. So they really recommend medication treatment and behavioral therapy if it's available. So we're going to dive into a closer look at preschoolers with ADHD. And why do we do that? Well, to begin, I think that being within child development myself and having a degree in developmental psych, I think it's really important to think about the entire developmental curve of how these symptoms express themselves and when they begin. And when they begin early on, as we see here, and because we know that severe ADHD can be identified very early on, we need to really consider how we are treating these children and how carefully we're approaching them with getting the right treatment. So we start with the epidemiology of the ADHD diagnosis and medication treatment among preschoolers 2 to 5 years of age. And what we find is that a little over 1% nationally of our preschoolers have a current ADHD diagnosis, and about half of them are currently taking ADHD medication. And that means we have about 194,000 preschoolers nationwide that have current ADHD. And about 77,000 of them are taking medication for the disorder. Now, when we look at changes over time, we see that in 2007 and 2008, the rate was just under 1% for diagnosis, and now is at about 1.5%. And so that's an increase of about 56%. And the increase in medication treatment has been 100%, a doubling in the percentage of children taking ADHD medications who are between 2 and 5 years of age. Now, as we would expect, there are regional variation. I can't do state-based variation because the numbers get too small for even my large national survey data. But we do see, looking at these 9 regions of the United States, that there's still in sort of central United States really high rates relative to the West for ADHD diagnosis among preschoolers. And we also see that treatment rates are higher among the Midwest to the east compared to the west. So the national rate for ADHD medication for preschoolers is about 40% nationwide. And then for behavioral therapy, this is using the only data we have that includes both ADHD medication and behavioral therapy. We see that there's really an inverse. So I'm going to toggle back. This is the medication map, and here's behavioral therapy. There's really an inverse relationship. And when you run a correlation on this, you see a negative relationship, an inverse relationship between behavioral therapy and medication treatment. And that gives us a clue that there may be some elements of availability of behavioral therapy here driving some of these patterns. Okay, and then this is a complex map that I don't want to talk about too much. We're trying to get at the percentage of preschoolers who are not receiving either medication nor behavioral therapy. We really didn't have fantastic estimate stability. Those crosses indicate that we have really large relative standard errors, and so I don't want to interpret it too much. But I do want to say that there are children in the United States, preschoolers, who clinicians are probably taking a more wait-and-see approach. And that's also probably appropriate for a large number of children, trying to understand where the symptoms are coming from and how do we account for them. And with that, I'm going to pause and pop out, and Mr. Bilbo is going to give me a break while he talks a little bit further about what he has found in Louisiana using your own data.
Thank you, Dr. Visser. Good morning, everyone. It's an honor to be here. This is the culmination of a lot of people's efforts and ideas. I get the pleasure of presenting them to you. My name is Ryan Bilbo. I began working at Department of Health and Hospitals 3.5 years ago. Previously, I worked at LSU, focused on economics, public administration. And while working and studying for 8 years in the Division of Economic Development, the application of business intelligence and GIS software, Geographic Information Systems software. I'm currently part of a new center here at DHH within the Office of Public Health called the Center for Population Health Informatics, newly formed by our Assistant Secretary, J.T. Lane, and under the direction of Joseph Foxhood. Over the past year, we've been looking at ADHD prescription rates in Medicaid, and we've had a lot of help from our partners in Medicaid quality management, statistics, and reporting. Dr. Lee and Bai-Fu Zhu, these guys are great staff experts that help me dive into the millions upon millions of claims that are filed each year and stored in our data warehouse. Assistant Secretary J.T. Lane, Secretary Kleber, Dr. Husty, all have been great supporters. Dr. Savicki, without their support and direction, this effort would not have been possible. I need their support to dedicate the amount of time it takes to show you what I'm about to show you today. It's exciting, and again, an honor to share our collective thoughts. So, without further ado, here's some of the major themes in the presentation that we'll revisit again at the end. But as we go through it, I'll show you how each one of these things were arrived at. The first point is just to reiterate what Secretary Kleber said about the Express Scripts study, that we're high. We have the second highest ADHD medication usage rate among the privately insured. The second bullet point there, among 4 to 17-year-olds, the CDC found in 2011 that our rate was 13.3%, I believe, in current ADHD rate. You'll see a lot of percentages used today, and they can vary from the more broad, have you ever been diagnosed with ADHD, to the more specific, are you currently taking ADHD medications? Louisiana is high relative to the rest of the nation, and we see that across all of these statistics. And we also see some patterns, as Dr. Vitzer noted very well in her presentation, of increase. In Louisiana, what I'm about to show you is specific to calendar year 2013 in our Medicaid population. 64% of our children ages 4 through 18 in Louisiana were at some point in 2013 enrolled in Medicaid. So we have a pretty good view of what's going on with the majority of our children in Louisiana just by looking in the Medicaid claims data. 12.9% were prescribed an ADHD drug at some point during the year. The highest rates were found amongst white male 10-year-olds, 35.8%. So when you hear these percentages that are in the low teens or single digits, which you sometimes don't see or what's not revealed under the covers, is that particular cohorts in that global population have a really high rate of prescription. And that's shown here with the white male 10-year-old population in Medicaid having a rate of 35.8%. That's 3 times the rate for the state. The birth date cutoff for early entry into kindergarten is September 30th. So if your child's not 5 years old on or before September 30th, they can't enter kindergarten in the public school system across the state. So those born in September, we found, were 26% more likely to have an ADHD prescription than those born in October. There's some fluctuation in that statistic. I know Secretary Kleber mentioned earlier a higher difference, and depending on when you look and whom you look at, that can be higher or lower, but there is a marked difference in the prescription of those children born later in the summer. And that's before we remove those kids who were entering late. So I think it would really be telling if we knew who amongst those September births were entering school early versus late, and then we would see an even bigger difference in the prescription rates. The ADHD prescription rates vary across geography. I wanted to make mention here that these ages were calculated in our Medicaid claims data as of September 30th, 2013, in keeping with that cutoff date. So all the ages, the age range that I mentioned here in this 2013 cohort, is that age was calculated on that date for that reason. This date was chosen because of the cutoff, the rules about entry into kindergarten, and let's see, those under age 4 by that date wouldn't be in pre-K. So it's a succession pattern. So what we see in the kindergarten early entry dates is reflected as well, I believe, in the pre-K dates from what I've read. The other end of the age range, 18, was chosen because those 19 and up must meet more exclusive criteria to remain enrolled in Medicaid. Likewise, those over 18 may have completed high school and therefore are not found in most research on childhood ADHD. So this is just another normative slide from the CDC, a really good graphic about where rates have been in the past. I think Dr. Vitzer's already shown similar information in one of her slides, that it's gone from single digits approaching 11, 12% in more recent years. The Express Scripts study released in March is the only content in my presentation that includes data on privately insured. But it's important to mention here, this research focused exclusively on a nationwide sample of privately insured. And what can be lost in some of these normative reports is that the cohort rates vary greatly. I'll repeat that again, it can't be repeated enough. Once you dive into the data, you see different rates by age, race, and gender, and those are concealed within the global rates. For instance, the rates increase with age through the teens among the privately insured. There's some indication that there's a plateau or some slight increase in rates, while in Medicaid in Louisiana they peak at around age 9 or 10 and then begin to decrease. This coincides with LEAP testing, as Secretary Kleber mentioned, and is something that is concerning. for us when we look at the claims data. So let's begin here by taking a look at the scope of ADHD in Louisiana Medicaid school-age population. This large blue circle represents the entire Medicaid population in Louisiana, and if you just took out that portion that were under age 19, that would be in the green circle. Now, within the green circle are those age 4 through 18. It's very rare that a 3 or younger year-old child would be prescribed with ADHD medications. We'll see that in a minute. And it's important to, again, to repeat that 64% of these children, actually 64% of the children in the state of Louisiana, ages 4 through 18, were on Medicaid during that year. Were they on it consistently? Well, 517,000 were on it for the entire 12-month period. The remainder were either on it for 1 month or more. So here we have how we see how few 0 to 3-year-olds are prescribed ADHD medication, as well as the static nature of the peak. These 3 vertical bars represent 3 different years' worth of data from Medicaid claims, 2010, 11, and 12. And you can see how over the course of those 3 years, the number of prescriptions written went up, as well as the peak at 9 to 10 years old staying static, staying the same. It didn't advance forward with that age group. It stays the same there. So I thought that was pretty interesting. In our next slide, what is not seen in the overall rate of the 12.9%, and the rates by specific age year is how different age, race, and gender cohorts were prescribed ADHD medications. White male 10-year-olds had an ADHD rate 5 times larger than females who were in the other category here. I split our Medicaid population up in 3 groups: white, African American or black, and other. So there we see the different rates by age, by race, and by gender. The largest rates being amongst the white males. That's the set in the back, and the lowest rates being among the females of other race. And that's the set in the front, and the numbers or percentages are represented in the table in the bottom. So I think what Dr. Visser was saying earlier was that females versus males is roughly a 2 to 3 to 1 ratio, and in Louisiana we're at the far end of that. We're closer to 3 to 1 when comparing males to females, and that's not readily evident here, but you can see if you combine the male columns where you might arrive at that. So when do they start? This was a big question from Dr. Hussey, and a challenge to look across multiple years of data to find out when the first prescription was made in our Medicaid population. Now, for those born during or after 2002 who would be 12 years old by now, roughly, the claims for ADHD prescriptions were queried between 2005 and 2014. Why 2005? Well, they would have been age 3 by then if they were born in 2002 or after. So they would have been at least 3 by then, and in most cases, the first ADHD prescription was given around 7 years old, plus or minus 2 years. So we can see that in that column right next to the 5 label at the bottom, that's your 6-year-olds, then 7-year-olds, 8, 9-year-olds. So if you added up all the percentages for each one of these columns, you'd arrive at 100%. It stops at 12 because we didn't have more than the 12-year-olds there. But you can see from this pattern that it would be pretty rare for someone older than, say, 8, 9 years old to receive their first prescription by that age and not before. This is the birth month pattern that we found. Each one of these separate, or each one of these, 12, 15 bar charts represents an age year. So the top left is 4, and moving to the right is 5-year-olds, 6-year-olds, 7-year-olds. And the columns represent the rate of ADHD prescription among them. And on the x-axis on each one of these charts is the birth month for that group. And we see consistently across each age group, starting with 6-year-olds, and in previous years we saw this in 5-year-olds, that there is a difference in the prescription rates when you compare July, August, September birth month cohorts with October, November, and December. It's indicated by the red arrows here. So that's could be that early entry into school results in behavior that is immature for grade level and increases the likelihood that a child is prescribed ADHD medications to correct for that behavioral disparity. We don't have proof of that, but we have some indication, strong indication of that here. And if we look across geography, this is where things get really interesting for me as the GIS manager. Relative to demographic, larger geographic disparities exist. Generally, the southwest of Louisiana has higher rates than northeast that persist. These higher rates in the south persist along the I-10, I-12 corridor, with the exception of New Orleans. We've considered many things such as patient and prescriber mix, school attendance zones, prescription patterns, etc. Differences at the regional level were expected to be small due to a large sample size, and they were not. If we looked at a smaller area, perhaps a zip code, we might be able to explain away a difference like this in random chance. A small sample was chosen and something odd was found in a zip code, say in Lake Charles versus Monroe. But when we're looking across these large areas and over 500,000 kids, roughly 50,000 per area, we don't see that. We see some pretty strong patterns. So what does that look like graphically? Each one of the vertical columns represents a DHH region, starting with Region 1, that's New Orleans. 2 is Baton Rouge. 3 is Houma Thibodeau. 4 is Lafayette. 5 is Lake Charles, the highest. 6 is Alexandria. 7 is Shreveport, 8 is Monroe, and 9 is the North Shore. It picks back up again when you move to the southern part of the state here in Region 9. So if you look across the state, the average is 12.9%. If you look in any one of these regions, it can be higher than that depending on what part of the state you are in, or lower. So among Louisiana's Louisiana DHH's 9 administrative regions, there are large variations. So this is my attempt at humor here. I used a Probit model to ask the question, what was the probability in 2013 that a child in Louisiana on Medicaid of a certain age, 4 through 18, a certain race, white, black, or other, and gender would be prescribed medication for ADHD? And to do this, I used a Probit model to predict the probability between 0 and 1. And the Probit had some very simple assumptions behind it. It wasn't meant to be the end-all, be-all model. I think the most interesting part about this model is that it fails, not that it succeeded. We didn't include geography because we didn't think that geography would be a predictor. And an example of a Probit, if you will, is here we have that dots at the top of this Probit chart and that indicate people who liked Justin Bieber, and at the bottom, those that didn't. And the axis at the bottom represents the number of beers they had consumed. The probability that they like Justin Bieber increased as more beer was consumed. 6 seems to be the magic number. So if you don't like Justin Bieber, you can have 6 beers. Justin Bieber did not agree with this study. So after running that Probit model using age, race, and gender as the only predictors of the probability that someone would be on ADHD medication, we found some explanation of the variation from the state norm, but not a complete explanation. So what you see on the left are the actual rates in the darker bars, and the lighter bars represent the predicted rates. And if you look at Region 5 in the middle in particular, you see that given the age, race, and gender mix in Region 5, we would expect to see higher than the state normal, but not 19.7%, perhaps 14.8%. So what's left there is things that the model is missing. account for that variation in the model. And if you map these things at census tract level, this is what it looks like. And from here, it looks rather light. I'm gonna step around the podium so I can have a better look at it. If you look in the middle, there's a red band that extends from the southwest part of the state to roughly the Angola area, and then from south central up towards Slidell. Region 1 had lower than expected rates. What you see in red here is where the model predicted a higher number of kids, or actually a lower number of kids on ADHD drugs than we actually saw. And in blue, it's predicting a higher number of kids than we actually saw. So these are the differences. This is the error in the model. And the most telling part about this slide is that the error is not randomly distributed. The error is in the southern part of the state. Thank you. So that the error would be in the southern, that the error would be high, or in the positive direction in the southern part of the state versus the northern part of the state, was the most interesting part of that effort. Region 8 had the lowest number of ADHD prescribed Medicaid enrollees relative to our prediction. Each tract is labeled with the difference, actual minus predicted. So we see in this large census tract out to the right that 26 fewer children were prescribed ADHD than we expected based on the age, race, and gender rates that we see across the state. There were some exceptions. I believe in that top left corner you can see a census tract that had 20 more than expected. But by and large, the general pattern here is that most of the values were negative or normal. The tracts that were normal were not labeled with a number. It was just those that were in the highest or lowest percentile. So Region 5 had the highest, and you can see here all the numbers are positive, meaning that we predicted fewer would be on ADHD medications based on their age, race, and gender rates across the state than were actually on it. So we have some really high numbers here. In some of these areas we have over 84, I see, 94. I think in one place we had actually triple digits. So it's really interesting that the model failed in such a predictable way, indicating that perhaps geography is important. So East Baton Rouge Parish has both census tracts with higher and lower than predicted enrollees with an ADHD prescription. This can be seen at higher resolution and relative to school attendance zones. So that was one question that was posed by the work group, is what if it was certain schools that were pushing ADHD prescription for their students? So we wanted to take a look at that. The next slide focuses on this particular area in central Baton Rouge. This is the area just southeast of the airport, and a neighborhood within it that has three elementary schools: Forest Heights, Marydale, and Glen Oaks. So a little bit about the map. I think you'll notice that here we had these geographic units that were kind of fixed, and here it looks more like a weather map or a heat map. The way that this is done is that we geocode all of our Medicaid enrollment monthly, and when we do that, we're able to assign those differences that I showed you earlier in the predicted minus the actual rate. And then when we average those differences across neighborhoods, we can come up with a more our higher resolution version of this red-blue map, showing us actually where these dividing lines are between higher than expected and lower than expected ADHD prescription rates. So again, schools have been discussed as a possible driver of ADHD prescriptions. School attendance zones overlaid on local ADHD prescription rates indicates that hotspots do not necessarily follow attendance zones in this area. We see that they overlap the attendance zone, in particular the southern border, the Glen Oaks Park Elementary attendance zone. I stress that this is only one part of the state. Perhaps in other parts of the state we would see more agreement between these hotspots and attendance zones. But getting attendance zone data for the state has proven very difficult. I was only able to get this for 5 parishes, and that was through a federal entity, that the Department of Education, that was able to get this information off the internet. Most of our parishes do not have electronic versions of this that you can download, or even text descriptions that are available to define their attendance zone boundaries. So this was really difficult, and I stress again, this is just one part of the state, but the goal here was to find out if attendance zones would be perhaps a predictor, and here I don't think that's the case. Of interest, though, is that Forest Heights Elementary is a performing arts magnet school, and Glen Oaks Parks has a gifted and talented program. So that was kind of interesting, perhaps maybe driving higher rates of prescription. Still more to be researched there before we can say anything definitive. So the second question that was posed is, could it be a lone actor? Could it be one prescriber that's driving high rates in an area? So we focused on the hotspot again, and we counted up the number of kids who are prescribed, and from whom, most importantly, they received their first prescription. Who was their sentinel prescriber? And we found that in this particular area, there were well over 100 prescribers, or well over 100 kids who received their first prescription in this area, and 16 were attributable to one prescriber. No more than 16 were attributable to one prescriber. So that kind of that dispelled that particular theory in this area. Looking in other areas, I've found that there are certain prescribers who do prescribe a lot of ADHD medications, but they're not necessarily driving higher rates at the parish level. And another thing was, if they are prescribing, if a particular prescriber is the first-time prescriber for a lot of kids, if they're a sentinel for a lot of kids, then perhaps they're prescribing earlier than others. That wasn't the case either. So prescriber types, this is going to wrap it up. Finally, questions arose and continue to arise, and we return to the claims data for further explanations. Recently, we found that first-time prescribers vary by specialty, but for the most part include pediatricians, psychiatrists, and family practice physicians. Last night, I did something interesting at the midnight hour, trying to figure out if access to these physicians across the state varied, and perhaps that could explain why prescription rates were higher in some areas than others. And what I found were that doctors are pretty good at sorting themselves. The invisible hand works. There are just as many physicians per capita in one area as another, and that didn't readily appear to me to be an explanation as to why there were higher rates in the Southwest versus the Northeast part of the state. There's more work to be done there, though, but initial indications are pretty strong that that's not the driving force behind this. So in summary, Louisiana Medicaid by health versus express script sample, there's a couple contrasts, both samples, similarities and contrasts. Both samples indicate that ADHD prescriptions are rising. The express script sample privately insured rates are high as well. Medicaid ADHD prescription rates from 12 to 18 are not higher than 4 to 11-year-olds in Louisiana, unlike the express script samples where they are. So the privately insured are perhaps staying on the drug longer or being introduced to the drug later than our Medicaid population. And rates for some cohorts are much higher than others. Definitely we see that in the white male 10-year-old, 9-year-old versus, say, an other race for female 18-year-old. So the geographic disparity in Medicaid ADHD prescription rates is pronounced in Region 5. It cannot fully be explained by demographic variation, assuming that those are a factor. Attendance zones don't seem to explain it. There doesn't seem to be one single smoking gun. It seems to be a multitude of factors that can vary across geography. and we need to take a further look into that to see what it is that matters most in each particular area. That's my feeling after looking at all of this. The top 10% of prescribers in terms of days supply prescribed, it was comprised of, this was interesting, 1,000 prescribers. They were responsible for over 1,100 prescribers, responsible for 78% of the supply statewide. So 500,000 kids plus 1,000 prescribers prescribing 78% of the medication to them. I thought that was interesting. Further analysis on the network adequacy, which I started last night, is being done. How many are receiving ADHD prescription, also receiving behavioral therapy? I haven't looked at that yet in the claims data, what the overlap is. And then how many were diagnosed with other things such as autism. And then more links to school data to perhaps explain why certain areas might be higher due to peer effects at their school. And that's all I have. I'll pass it back to Dr. Visser for now. Thanks.
Thank you. That was fascinating, Mr. Bilbo. It's such a pleasure to have really complementary in-state capacity like that, to dig in and get down to your parish level statistics, really be able to address issues of hotspotting, which has been important for example, in the opiate investigations, really trying to understand if this is really being driven by individual prescribers or if this is something that is more generalized across the state. And really considering hotspotting and geographic dispersion methods is really, really important. And you also see from what Mr. Bilbo presented that, you know, when you dig in, there's so much happening at the state level, at lower levels in counties and parishes, in neighborhoods. And so what we've done is in the beginning of in 2013, I was presenting some information on the national and state-based trends of ADHD, and there were some Georgia state officials that were in the audience who said, you know, you're in our backyard, this is such an important issue, help us to start to address this and help us try to figure out how to dig into our own data. And we are a technical assistance agency. Any state who calls us and asks us for help, we will help within our resources. And so we availed ourselves to them. And a small team of mine began this initiative with Georgia that I think is a nice example for you all to consider and to help guide your investigations and thoughts about what might be happening here in Louisiana. So Georgia is a great proof of concept state to consider because it literally ranks right in the middle, 25th in terms of relative prevalence in other states. And what we wanted to do was start thinking about those diagnostic and treatment guidelines and the recommendations and try to juxtapose what's happening in the state in terms of current practice versus best practices. And so we wanted to begin by looking at children who had 2 or more ADHD diagnosis codes in their records. And these are all children in Medicaid because that's the data that states have available to them. And so we wanted to group it by the age groups that AAP recommended in terms of treatment recommendations. And so we looked at the 4- and 5-year-olds. We looked at the 6- and 12-year-olds. And they wanted to keep it sort of in the birth to 12-year age range because that's really where a lot of the federal initiatives are heading right now, looking at sort of early childhood. And so what we found was that 5.6% of the 4- and 5-year-olds, those preschoolers, had 2 or more ADHD diagnosis codes in their records in 2012. And May Zhao, who was running these data for me for Georgia State University with a data use agreement with Medicaid, also just sent me the data for 0 to 3-year-olds because statistics tend to be complete in that way. And it was non-zero. And I wondered, you know, what's going on there? So I had her strip off the 0- and 1-year-olds, and we found that actually 1 in 100 toddlers, 2 and 3 years of age, in Medicaid in Georgia had 2 or more ADHD diagnosis codes. And it was really surprising to all of us that we would see that many children who had 2 or more ADHD diagnosis codes in their records. And then, of course, we wanted to look at treatment. So we compiled a list of FDA-approved ADHD medications. So this doesn't include anything that's off-label for ADHD treatment, but all FDA-approved ADHD medications, as well as a list of anything that looks like it could have been behavioral therapy. So individual psychotherapy for 30, 45 minutes, 60 minutes, group therapy, family therapy, any kind of behavioral intervention that we could find, play therapy, anything, both evidence-based and not. And we wanted to generate an estimate of the percentage of these children in each of these groups who had ADHD who were receiving medication in the past year, and then the percentage who were receiving behavioral therapy. And here's what we found. For the preschoolers, who was really the target of the investigation initially, we found that 3 out of 4 of them were receiving FDA-approved ADHD medications. And about 44% of them were receiving anything like behavioral therapy, evidence-based or otherwise. And right there, that was our indication that there was a misalignment between current practice and best practice for ADHD treatment in the state for the Medicaid population. But what was further astonishing was that for the 173,000 toddlers in Medicaid, about half of them, 1 in 2, were receiving FDA-approved medications for ADHD, class 2 controlled substances for the treatment of ADHD. And that was 760 toddlers in our state in Medicaid receiving those meds. And it was really surprising, about the same percentage were receiving anything that looked like behavioral therapy. And so this really raised the alarm. The New York Times covered this. They extrapolated that if you took these rates, because Georgia is an average state in terms of relative prevalence, and you generalized it to the nation, we would expect that no less than 10,000 toddlers nationwide would have taking medication for ADHD. And we're corroborating those statistics right now by CDC. But in the interim, we further looked at the eligibility categories within Medicaid, and we found that the rates of 2 or more ADHD diagnoses were highest among the foster care and adoption assistance group, which is, I think, what you would expect given higher environmental and social risk experience in that group. And then the next largest group is SSI waiver group. When we look at rates of ADHD treatment for each of these eligibility categories, we find that there's no differentiation across these eligibility groups for medication treatment, but there is for behavioral therapy. And we see that for foster care and adoption assistance, those kids are getting the highest percentage of them are receiving behavioral therapy at 69%. We wanted to make sure that these patterns were, A, not unique to Georgia, and B, not unique to Medicaid. So we ran these same analyses in the TrueVin market scan treatment pathways database to try to understand and really get some corroborating evidence that this was happening nationally and also in the private insurance world. And you can see in this first 2 sets of bars, the private national estimates for 2 to 3-year-olds against the Georgia Medicaid estimates, and they're almost dead on. They're really, really similar. And when you look at private national for the preschoolers and Georgia Medicaid for the preschoolers, again, almost identical. So that really gives us a confirmation that Georgia is a good proof of concept state. And it also suggests that this is a pattern, a set of patterns that are happening nationally and regardless of insurance status. And I'd like to point out that that makes good sense. I mean, physicians are not likely differentially making treatment choices as a function of the insurance type that the child has. And I think that's really important. I think physicians get a really bad rep in many ways in terms of behavioral health, and really this really the exception rather than the rule that physicians are being flippant with the types of decisions that they're making. They're trying to do the best with what they have available to them, and they're not making decisions as a function of insurance status, I don't believe. So why are we focusing in on really trying to improve the provision of care for these preschoolers, and why does treatment with a medication that is known to be very, very effective and generally safe, why are we looking more carefully at this group? The answer is that we know that behavioral therapy is the safer alternative for these young kids. And there was a study done by Weigel in 2006, Weigel and colleagues, that compared the adverse events that all children with ADHD experience, which include appetite loss, sleep problems, elevations in heart rate and blood pressure, irritability, mood problems. All of these things happen in all children with ADHD. But Weigel looked and compared children who were preschoolers who were receiving these medications and their adverse events against older children. And what they found was that there were unique patterns of adverse events for the youngest kids with, in addition to all the side effects that you would typically expect, they had much higher rates of adverse events associated with appetite loss, sleep problems, stomach aches, and GI problems that can sometimes be really debilitating, social withdrawal, and also lethargy. And so, in addition, they're experiencing these additional adverse events, and there is a really fantastic alternative. So in the case of ADHD treatment, we have some really good comparative effectiveness studies that pit parent behavioral training against medication. And there's sort of a third row that I put out in this comparative effectiveness table that includes combination therapy. There's just not enough of it out there. We could draw no conclusions about that. But the Agency for Healthcare Research and Quality, AHRQ, did this comparative effectiveness review and found that the strength of the evidence for recommending parent behavior training for young children under 6 with ADHD was high. And there were this SMD indicator of -0.68. That's a standard mean difference indicator, which means that you can expect about 0.7 or almost 3/4 standard deviation of difference in ADHD symptoms when you use parent behavior training. And they found that the programs that were effective offered at least 2 years of impact. So once you receive this parent behavior training, you get at least 2 years of maintenance, or approximately 2 years of maintenance. There's also a dose-response effect. So if you consume more parent behavior training sessions, your child does even better. For medication, the strength of the evidence was determined to be low, and it wasn't because it's not effective. So you see a standard mean difference there of 0.83, so just a little bit higher than we saw for parent behavior training. And that means, you're getting to 4/5 of a standard deviation of difference, which is really high and very good and consistent with what you see in older children, just a little bit lower than what we see in older children. The problem is we don't know enough about the long-term impacts. And without that information and knowing that these children's brains are developing at a rapid rate, we just can't conclude that it's safe for use at this young age, particularly when there is such a fantastic alternative in parent behavior training. So I think that's really important. I think it's also important to consider cost here, and policymakers really like to understand what they get in terms of cost savings long term for different types of interventions. And this figure comes from a cost effectiveness analysis that came out of the multimodal treatment of ADHD trials. It's really our best set of studies that compares medication alone to behavioral therapy alone to combination therapy to community treatment. And in that study, they also looked at the cost effectiveness of those treatments and found that for the third of children who only ever develop ADHD, they never develop any other co-occurring condition, ADHD medication alone really is the most cost-effective choice. That's what they need, and they do the best with it. But for the 2/3 of children that have some other co-occurring condition, including anxiety and OCD or CD, conduct disorder, or oppositional defiance disorder, you have to add behavioral therapy. And for anxiety, behavioral therapy alone is really the most cost-effective choice. And for comorbid conduct disorder or ODD, what you see is actually that you need both. So behavioral therapy is an important component of treatment, and it can be very, very cost-effective with or without ADHD medication. So the other component here is that we know what works in terms of behavioral therapy. Sometimes you only get information about specific programs that have been shown to work in specific populations. We have in what was a large review conducted by AHRQ, a systematic review of what works for treatment of preschoolers with ADHD in particular, and they recommended parent behavioral interventions as a good treatment option and identified 4 specific programs that have been tested across numerous communities, across numerous socioeconomic strata, and they have been tested and retested with children with co-occurring conditions and without, and different types of disruptive behavior disorders. And what they found is that these 4 programs, and I should say positive parenting programs, scratch the preschoolers, I added a 4th P, triple P, But P, Incredible Years Parenting Program, Parent-Child Interaction Therapy, which I know you have some roots here in Louisiana that are growing, as well as New Forest Parent Program. New Forest was developed specifically for ADHD, and it only exists in the UK. So not much help to us here. Parent-child interaction therapy is the only one-on-one therapeutic delivery mode out of these programs. The rest are all group-based interventions. And all of these can be delivered in somewhere between 6 and 18 sessions, depending on the program, but there are a finite number of weekly sessions typically. Now, ARC took and the authors looked at the different components of these effective programs and concluded that there were some similarities here. They all helped parents develop a positive relationship with their child, so they're focusing on parent-child interaction. They're also teaching them about how children develop and what's developmentally typical. And they're also helping them manage negative behaviors with positive discipline strategies like token systems, for example. Now, what we have in another important piece of literature is a study that was conducted by my now team lead, Dr. Jen Kaminsky. And she actually conducted a meta-analysis of these components and said, what are the components that are most effective for doing two things? The first outcome was parent behavior and skill acquisition, so having the parent learn something and gain skills in parenting. And the second, which is really important here, is the child externalizing symptoms. And when she looked at 77 published studies for kids 0 to 7 years of age, she found that for the acquisition of parent skills, there were two components that were most robust, most predictive. And those were teaching parents relationship-building communication skills, really how to talk to their child and build a positive relationship with their kids, and modeling that. And the second was having those parents practice it and having someone guide them. That was really important. For the second set of outcomes, the child externalizing behaviors, which is where we would find our ADHD behaviors, the most robust predictors were teaching parents to interact positively with their kids and providing positive attention, finding opportunities to say, I really like the way that you're interacting with your sister right now. Thank you so much for putting up your book bag in the hallway hook, that sort of thing, to find opportunities to reinforce the positive and not dwell so much all the time on what, of course, happens to all of our children at some point, the negative behaviors that we have to discipline. And then also teaching parents consistent disciplinary responding once you have to discipline them. And here, again, positive strategies like token systems are really important. So unfortunately, the programs for which we have the greatest evidence, on the right-hand side, the most evidence are at the top. We also have the least availability. And as I mentioned, we don't have a New Forest program here in the United States. In the Northeast, I believe they're testing one application of it, trying to generalize to the United States. P and Incredible Years are spottily available. And all three, P, Parent-Child Interaction Therapy, and Incredible Years, require that you pay upfront, usually for a set of people to be trained. And they'll come and they'll train you, but it's not cheap. It could be $10,000 for a group to be trained and reach certification, and then you have to worry about being recertified and maintaining your certification. Sometimes there are fidelity reviews. So this is not for the faint of heart, these programs, but they're incredibly effective, and they are the best for our young children with ADHD. Going down a tier, where we have a little bit more availability, are what I would call the promising component programs. So these programs are formal programs where they come out and they're proprietary. They train people on the effective components that we were talking about, but they don't reside within a branded program. They're teaching the clinicians, you know, if you administer the following types of activities and engage in the following ways with your parents and children that are consistent with the effective components of the programs, you should have positive impact. So there's a little bit more of that, and there is some training and associated fees, but it's a little bit less expensive than the branded programs. And then finally, we have clinicians who basically, you know, understand those are the sorts of services they should be providing, and they endeavor to provide those services within the context of their clinical environment. And so these would be any kind of clinician, clinical or developmental psychologists, licensed clinical social workers, behavioral analysts, and even some really scrappy psychiatrists I have seen attempting to deliver behavioral therapy in their settings because they don't have a psychologist that they can refer to. So now I'm going to talk a little bit about the availability of people who can provide these sorts of services. And we'll talk specifically about psychologists and psychiatrists. And also we'll talk a little bit about child and adolescent psychiatrists. So when we look at the employment of clinical counseling and school psychologists who might be able to provide some of these services, you find Louisiana at the lower end here in the bottom group in terms of employment of these psychologists. And when we look at it a different way, it's the same indicator, clinical counseling and school psychologists in the state, but it's in the format of a location quotient. So it's really looking at concentrations of these providers and looking at them relative to other occupations in the state. And you find a really, really low location quotient, very low concentrations of clinical counseling and school psychologists in the state. When we move on to psychiatrists by state, again, you see Louisiana falling in the bottom group here. In terms of the number, we've got 40 to 110 psychiatrists within the state, and they're, again, really, really low location quotients relative to other occupations within the state and other states. Now, the American Academy of Child and Adolescent Psychiatry, of which Dr. Gleason is a member wherever she is, they have some really fantastic data that gets at really low levels, and they're trying to show you the rate per 100,000 on the left of child and adolescent psychiatrists. And the blue that you see most of means there's zero. There are no child and adolescent psychiatrists in those counties. And to the right, you see the number per county as opposed to the rate on the left-hand side. And so there are some pockets here where you have 10 to 15, all the way up to 50 child psychiatrists that are in these counties. So there's some spotty availability, but for most of the state, you don't have a child and adolescent psychiatrist 4 miles. So when we're thinking about how to impact this very, very complex system, and as Mr. Willow said, we know that there's a multitude of factors that are influencing this, we turn to policy practice program and look for opportunities to guide our clinical practice and family choice. And as my deputy director, Dr. Ileana Arias, noted recently at a meeting with our Georgia health commissioners, policy is really the context that you provide to guide behavior. And it sets a floor sometimes for what is expected. And through policy, we can communicate what the best practices are and support better behavior and better choice, better family choice. And I think this is important here because the issue is so complex and we have so many barriers that we've already talked about. This is a conceptual model where I've tried to wrangle some of this for you. And at the top you see, so you have a child who's under 6 and they're diagnosed with ADHD by a clinician. And you move into the context. So the context is we have healthcare practitioners who maybe don't know about the diagnostic and treatment guidelines. Maybe they don't know about the best practices. Maybe they know about them, but they have strong preferences because medication works, and it's generally very safe and very, very effective. Maybe they know about the family history in the family of ADHD and know that the older sibling has responded really well to the medication and really want to put the younger child on it because they know in a couple of years the child's going to need it also. So they have all of these preferences and resulting behavior. They also have family barriers, and those barriers include family preference for medication. Why can't we just do what we did with an older sibling? Or I've heard that this medication is really effective. Can I please have it for my child? And it really interfaces with these healthcare providers. They need to be able to justify why behavioral therapy is better for a young child, why it's the better choice, and why it's important to try it first. And that can be really difficult, particularly when you're dealing with families who can pick up and go to the next doctor and doctor shop. And sometimes that will happen. Also, families don't necessarily understand the benefits of behavioral therapy, but it's also a lot of work. It is a lot more work to invest in behavioral therapy strategies. And the reality is that for some families, they don't have an hour every week or more to invest in going to receive the behavioral therapy for long stretches at a time. And so that's a reality we need to work within. Also, there are infrastructure deficits. And we're at the place where we know that there's a limit to the number of providers who can provide behavioral therapy. And also we're concerned about the number of people who can provide the evidence-based therapy, particularly for these young kids. So we have to deal with those. And finally, reimbursement barriers. In Georgia, there's such variation. Even within Medicaid, there are 3 health plans in Medicaid, and across the 3, a community service board could get anywhere from $30 for an hour of behavioral intervention all the way through to $106 an hour for the same types of services. So we know that it is very frustrating for behavioral therapists to be able to create a sustainable environment to provide these interventions. And we have to look into the realities of that and try to look for creative solutions. So addressing these 4 sets of barriers is going to be really important. I think in my discussions with my leadership, as well as behavioral therapists and clinicians, it's so important to address the behavioral therapy infrastructure deficit alongside whatever you do in policy, because if we increase referral rates and we don't have the behavioral therapist to provide the services, we're taking away the medication perhaps, but we're not providing them with a good alternative for treatment. So it's so important to work across context here. So I want to talk a little bit about what states are doing and what we've gathered. There's a lot of work that has happened in this area out of the GAO report that put a spotlight on high rates of psychotropic medication use in foster care. And out of that came some state policies and programs that do the following. Some of them require additional justification if you want to prescribe a psychotropic med to a young child. They'll ask about, who is the provider, what are they treating, what are the target symptoms, what other things have you tried, that sort of thing. There's also pre-authorization and peer review for any kind of prescription of any kind of psychotropic medication in a young child. Offering psychiatric consultation lines, particularly for primary care, if they need a consult, I'm not sure what to try, or if they're looking for someone to connect with to provide behavioral services and psychiatric services. Also, data registries, both for the provider, the prescriber, as well as the child. And folks tend not to love this when it involves the child being part of a registry. What I mean by data registry for a healthcare provider are basically hotspot logs where the state monitors hotspots and then puts prescribers on lists and tries to provide additional training for them, telling them that their rates of prescription for psychotropic meds are really high, and working with them to try to diversify their treatment portfolio, if you will. And then finally, preferred drug lists. And pretty much every state has preferred drug lists, and a lot of this came out of cost containment, but there are preferred drug lists in every state. So the policies that relate specifically to ADHD medication treatment for young children are fewer. Fewer states have these. They include things like having a preferred drug list that considers FDA approvals, and this is one such example in Georgia. The state health plan includes some language that says here Adderall XR has an age limit on it. It's only allowed for children over 6 years of age, and that's because it's been approved by the FDA for treatment of children who are over 6. We also have pre-authorization and manual peer review specifically for prescribing ADHD medications in those under 6, and also requirements of psychosocial evaluation and non-medication therapies that are tried first before medication is approved. And an example of that is Arizona, where they have prior authorization for any ADHD medication for a child under 6. And the guidelines for approval are really quite substantial here. We have that you have to document that the child has ADHD, a diagnosis of ADHD. You have to confirm that the psychosocial and non-medical or psychosocial issues and non-medical interventions are being addressed by the clinical team in some way. You have to document that there's a psychosocial evaluation that was conducted before requesting the meds. And you also have to document non-medication alternatives have been attempted before requesting the meds. This is a really comprehensive policy in Arizona. Also, health plans and insurers are taking and making some really smart choices, trying to get control over psychotropic medication patterns in their states. And I've seen a number of different things. Here's a select number of them. First, having alerts that come in when there is a prescription for 1 or more psychotropic medication in a child under 6. An alert will pop up. An alert for 2 or more or 3 or more psychotropic meds for any child, and really engaging in a conversation with those prescribers to find out what's going on there. Also, having 2 or more prescribers who are prescribing the same psychotropic medication to the same child. And sometimes this happens very innocently where there will be a referral from a pediatrician who will write a prescription for a stimulant, and then they'll be referred over to a psychiatrist who will write another prescription for a slightly different, name brand medication, but it's basically another stimulant. And so the child is receiving really twice the medication that they need. And as well as alerts for high doses of ADHD medications in excess of the FDA daily dose recommendations. There's also targeted communications happening with these health plans and insurers with physicians, and really communicating with physicians who are involved in any of the alerts above. And also some plans are doing strategic dissemination of the ADHD guidelines. So if a young child is diagnosed with ADHD who's under 6, really giving them a one-pager that summarizes what the guidelines recommend for these young kids and reminding them that the guidelines exist and what they should be doing. Now, just really in closing, I want to talk about the importance of evaluating any policy that is implemented. This is a quote from Milton Friedman. One of the great mistakes is to judge policies and programs by their intentions rather than their results. And we know that in policy, when you implement something, it has a really broad impact. And sometimes you'll see improvements in the treatment patterns, for example. Maybe we see decreases in medication rates, but not increases in behavioral therapy rates. Or maybe both of them improve in the way that we would want them to, but families are miserable and they're not getting what they need, or physicians really feel like they're being pushed into a corner and they're not able to provide the best treatment for their children. So I think evaluation is really key here. Before I shut down, I think I have just a couple of minutes, and Dr. Savicki asked me, and there was some interest in the room about diversion of ADHD medications, so I wanted to speak a moment to that. And just to say that with the increase in the diagnosis of ADHD and the medication treatment patterns, we do have more stimulants that are available for misuse, abuse, and diversion. And it's a major public health issue. In 2010, 7.6% of 12th grade students reported misusing Adderall. It's a really high percentage. And Adderall now follows marijuana and Vicodin in the list of the most commonly abused drugs overall. You can see that here. And by a student's own self-report, they say that almost 2/3 were offered prescription stimulants for non-medical use by the time they're high school students, and 31% of them will volunteer that they actually did indeed use them. And the motives that they cite is really for studying. They think it will improve the outcomes and their performance while at school. And you know, I've done some work with the National Institute of Drug Abuse, and the conclusions in this field are really that it does not help academic performance at all. It's a misperception. What it does is it improves wakefulness. So if you're able to stay awake longer so that you can study, certainly you're going to do better on a test. But when you control for wakefulness, children do not perform any better. So there's some misinformation out on the street. These aren't mental steroids. They're not going to make you do better on the test. If you have a Mountain Dew or some other, a mocha, and you stay awake and you actually study, you will perform just as well. So I think that's really important to try to get out there. And the most common source of finding these prescriptions are friends, almost exclusively. Finally, just calling your attention to the population-level impact for young adults in particular. We have seen really dramatic increases in the number of emergency department visits associated with non-medical use of ADHD stimulants. And they've increased from 13,379 in 2005 to 31,244 in just 5 years. So these increases are really not attributable to more adverse events among young children who are being medicated. This is really young adults and teens who are misusing these medications and ending up with heart-related symptoms in the emergency department. And with that, I will just say that we can certainly try to communicate a little more with our young adults and try to help them understand that what they don't know about ADHD medications can hurt them. Methylphenidate and amphetamine formulations are DEA Schedule II controlled substances. They can incur felony charges if they share and distribute or take medications, prescription medications from other people. And they have a high potential for abuse and can lead to severe psychological or physical dependence. Yet only 2% of the students in the Monitoring the Future survey say that these meds are very dangerous. So there's a little bit of misinformation out there that I think we could attend to with our teens and young adults. And now I will stop and take any questions that you may have. I'm happy to bring forward any other data or information that you guys might need to consider what you'll be doing in your breakout groups. Thank you.
Any questions in the room? We've just got a couple minutes. Raise your hand. I'll come over to you so we can get you on the microphone and make sure people on the web can hear. Oh, now I see you. All right. So right back here.
Hi, I'm Dr. Atkins from Aetna, and I'm wondering, have you looked at meds other than the traditional FDA-approved ADHD drugs, and specifically the antipsychotics?
In our work, no. And one reason for that is once you start drifting into other medications, the Medicaid director, particularly in Georgia, was very concerned about generalizing past what's really happening for ADHD. And since children with ADHD have so many co-occurring conditions, he really wanted to keep it tight to the FDA-approved medications. But you're right. These are all underestimates because we know that there are other medications that are being used off-label for the treatment of ADHD.
Great. Other questions? Yes.
I noticed that the region one numbers were less, and that was also where most of the child psychiatrists were in the state. So I was wondering, is that a common pattern that there's actually less diagnosis where there's actually child psychiatrists?
I don't think we know enough about that. What we're trying to do is get county-level information so that we can model that at a finer level. I will say that when I present data on treatment to psychiatrists at JCAP or at ACAP, for example, their conference, they really feel that as a group that medication is the way to go, is the most effective treatment. And so I would expect to actually find the most medication among the areas where we have more psychiatrists. But we'll be looking at that at the county level to see. And including psychologists is really important.
Other questions? Raise your hand high.
This is really to the gentleman who did the presentation on demographic and geographic patterns. I was wondering if you, when we were looking at those regional differences and those parish differences, if you looked at poverty and fetal alcohol syndrome in those areas and how that may have attributed to some difference in the frequency of diagnosis of ADHD.
We did, and that's not the first time I've heard that question, so it just moved up the list.
Very good. Other questions?
Good morning. I did notice several evidence-based models listed. I was wondering, are all of those models open to peers, parents who have gone through the process, and youth? Are there opportunities for youth voice in some of this? A lot of this was claim data and things like that, I understand. But I'm wondering how much we've asked youth and parents themselves.
Yeah. So the evidence-based programs for preschooler treatment of ADHD are really all focused on the youngest kids, and they don't include peer support. What I think you're getting at is sort of the older children who can come in. And what I will say is that a CHAD parent-to-parent program is the program that I think has the best evidence, or not evidence, this is the problem. They lack evidence in their evaluation, but they have the best parent satisfaction that I've seen out of any ADHD-specific support program. We need to get better evidence on that particular program because it does include some of those components, and in particular, the parent-to-parent element where there's a parent leading other parents and trying to understand better what they can try behaviorally with their children.
And I want to mention that we have 3 certified parent-to-parent trainers in Louisiana.
That's great.
Yeah. And this is more for Ryan, but you mentioned about possibly looking into how many who were diagnosed with ADHD also had ADHD and also had autism and some other things. I'm wondering if to step outside of DHH and go into DOE, how many are identified with learning disabilities, because I think that probably drives a lot of this too.
Yeah, whenever we link data sets, we always have new questions that come up. That's one that we'd be interested in, but we haven't linked anything from Department of Education with our Medicaid claims data to date. We've just talked about it, and don't really know what that would take. I think it would take involvement from a lot more folks than just me and whoever the other data officers are at DOV.
Yeah, I think the best information we have on that is really from community-based studies that can ask or directly assess for learning disabilities, but more than half of children with ADHD in community studies have learning disabilities. It's tricky because we can't use claims data because learning disabilities don't typically get coded by physicians, pediatricians, and psychiatrists. So it can be really difficult to estimate. But our community-based studies are pretty consistent. At least half of kids with ADHD have an LD of some kind.
You guys are always in the back of the room. I could have run over. I don't know who was first.
I can probably speak last.
Okay.
Considering demographics and diagnosis of ADHD, and did you look at education status of the parents? Or I know you said these were all Medicaid patients, but would there be any difference in income, household income, or education of the parents?
Nationally, I can speak to that. We do know that, starting with education, the highest rates of diagnosed and medicated ADHD are actually among high school graduates. It's actually lower for those who haven't achieved the high school level of attainment, and it's lower for those who have achieved more than a high school education. Strange pattern, very consistent over time. We have no idea what's happening there. It's sort of bell curve. But for poverty, it's pretty consistent. With increasing poverty, the rates of both diagnosis and ADHD go up, so that children in Medicaid, for example, or children who are at the poverty level are at least 50% more likely to be diagnosed and medicated for ADHD. Could you repeat that? So, Mike? Caucasians versus African Americans. So in Louisiana, that is true. Nationally, it used to be historically that ADHD was diagnosed and medicated more frequently among African American boys in particular, and then in the 80s and the early 90s it shifted and it was more likely diagnosed among affluent whites, and now it's dead on even. Whites and blacks have exactly the same rate of diagnosis and medication treatment. In Louisiana, it's different. I don't know, Brian, you want to talk about that a bit?
It's different, and that's really all we saw. We looked at the rates. We weren't trying to make any qualitative statements, just quantitative. And what you saw in that three-dimensional bar chart is the reality in calendar year 2013.
I would probably, throw SES, poverty threshold, into a model with race and see what happens. See if that's associated. I'm not sure what your patterns are in Louisiana in terms of poverty status and race and how they interact, but I would put them in together, and I suspect that it would at least temper it. I'm not sure in which direction. Yes, ma'am. Yes, they would have been, because Medicaid, yeah. She was, the woman up front was asking if children in foster care were included in the analyses, and definitely for Mr. Bilbo's presentation.
We didn't exclude them. I assume that if they're on Medicaid that they were included. There's no indication why they wouldn't have been.
So I found it strange because I saw in the handout that I usually found in white male 10 years old.
That's correct. White male 10-year-olds had the highest rate among all of the age, race, gender cohorts. And for the race cohort, or the race definition, I used Caucasian, African American, and other for the three categories.
One more question. John Wells for LSU in New Orleans. Just to go back to the behavioral interventions, I was wondering if you had any data about the utilization of the behavioral interventions compared to their availability, so whether they're prescribed whether people follow through with them, you know, what the strategies are there.
Yeah, I mean, we're looking at several states that have really tried to aggressively go after this issue. And Pennsylvania, actually, after Pennsylvania State initiated a series of events related to Sandusky, they actually rolled out incredible years across, I believe it was 11 counties, and had really, really high uptake for children who are at risk. And so I do think that there are good examples that when the programs are available, families do use them. And the satisfaction ratings for these programs are very high. I mean, families definitely like, especially the group-based interventions, they really love to be with other parents who are struggling with the same issues. And PCIT is just, there's really nothing better if you have a child, especially who's exposed to trauma or who has some other elements therapeutically. I mean, they do some amazing things one-on-one with a clinician. So different programs have different sort of strengths and weaknesses, but certainly their use definitely picks up when they're available, and we have some good models to show that.
Thank you. So it's lunchtime, and we want to thank Dr. Victor and Bill. What we've done this morning is really lay out the opportunities that exist in Louisiana across the country. Over lunch, you've got information in your handouts of different restaurants. Please be back by 1 o'clock, because in the afternoon we're going to take this information we learned this morning and start to put it to good use. So 1 o'clock, back here. Thank you.
Standard status services should be right now, currently, it could theoretically just be the kit itself, because all of the other service evidence is collected at Medicaid, right? So
I hope you had a good lunch where you discussed this topic, this important topic that we're working on today at the symposium. We've got a very busy afternoon. We've got a large panel that will present next, and then after that we're going to break out into our breakout groups, which I'll explain at the end of the panel, and we'll wrap the day up with a report out on what the breakout groups worked on and setting the stage for what we're going to be doing next to address ADHD in the state of Louisiana. We'll launch you all off into your workplaces, into your homes with work to do to improve the system of services here in Louisiana for folks with ADHD and their loved ones. So the panel before you, they're each going to have about 6 minutes or so to speak about some very important topics and some important projects that are currently underway. I'm going to let them each introduce themselves, but I'll give you an overview of the topics we're going to be covering. We're first going to speak about increasing comprehensive assessment and differential diagnosis for ADHD. Then we're going to talk about increasing behavioral health services for children with ADHD. And then we're finally going to wrap it up with increasing the ability of the home and school environments to manage variation in behavior and attention. Each one of the panelists will speak. They don't have slides, and we'll hold the questions at the end. If we have some time at the end to answer questions, we will. If we don't, we're going to move right into the breakouts. And for you on the internet, once the panel is done, we're going to move to breakouts, and you won't be a part of that, unfortunately, but we'll bring you back to the report outs with regard to the breakouts. So with that, I will start our panel discussion with Betsy, if you want to begin.
everybody hear me? Better?
Okay, now you can hear me. I'm Betsy Wilkes. I am with the Office of Behavioral Health and am excited to let you know about a project called Louisiana Launch. It's a joint project between the Office of Public Health and the Office of Behavioral Health. It's a federally funded SAMHSA grant, and it is a pilot project that's going to be located in Lafayette, Vermilion, and Acadia parishes. We
came up a lot of the data from the Kids Count book. There's a lot of rural poverty, lack of services in some of those areas, and we have situated the grant there. It will be governed by 2 councils. One is the state-level council that will work on changing policy, looking at what some of the barriers for reimbursements, working with the managed healthcare companies in order to change some policy. We have a local governing council that will take into account the needs in the area, what resources are needed, what's already there, and the goal of the grant is to increase capacity for services for kids 0 to 8. We're going to have 3 mental health consultants, 2 of whom are here with us today, and we're going to be working in 3 different settings or locations. The first one is going to be in child care, early child care areas, working with providers in early child care areas, working with teachers to help assess. Screening is a big part of this, to put in good evidence-based screeners that are going to be able to be used in various areas so that you're measuring apples and apples when you're coming back in for treatment. And in the early steps, the home visiting program is the second area that there's going to be a mental health consultant working with the folks that are already providing services for children with developmental disabilities and helping to do better assessments for emotional and mental health needs for the kids that are in those areas. The third area, and the one that I'm most familiar with and have more background in, is going to be in primary care. And we will have a consultant in primary care settings to help with utilizing screening, referring kids to evidence-based services in the community, doing some short-term work in those clinics. Parent training and family support is another big piece of this grant, being able to learn from our local council where those can be set up and structured that are easier for families to access and to get support from us on this. Another piece of this project, which is pretty big and complex, is that we are going to have psychiatric consultation services for the primary care folks that we're going to be working with. And Dr. Mary Margaret Gleason is going to be the child psychiatrist that will be available to help with some of the primary care physicians, pediatricians that are in the area. We're also going to have a perinatal psychiatrist that serves as a consultant for a lot of the OBs in that area to be able to address some of the family and concerns, the prescribing, find out what could be treated in primary care and what, in fact, needs to go to some secondary services. And then also to build support in those secondary services, as we were talking about this morning, to make sure that as we increase screening and we capture more and more of these children, that we have appropriate services to refer them to. My 6 minutes up. I'm a little worried about Jeff with the hook, right? I think this is a way also to take a look at what some of the services are that are already in those parishes. Make sure that we come up with a big data bank of what's available so that people understand what's being utilized, what's underutilized, how do you get into those services, how can we support those and continue to build capacity for all the providers that are already in those parishes. This is a pilot project. We hope that during the process of this that we come up with some really creative ways to sustain it, to be able to leave folks in the region as to help with this process, to continue it, and to come up with some really good ideas and to learn about how to replicate this in other parts of the state to access more services for kids. And it also ties in really well with the Integrated Care Summit that the state has been holding those in different parts of the states for several years, and our final one is in New Orleans a little bit later on this week. And to figure out some ways that we can continue to progress as a state with organizing better behavioral health research and folks that are working in integrated care settings in the way that it's been proven all over the country that's really better access to services as opposed to the siloed health cares.
Thank you. I'm Richard Dalton. I'm the Chief Medical Officer of Magellan, and I'm going to discuss today a 0 to 6 managed care program that Magellan is currently implementing. And it's not a program specific to ADHD, but it's an example of using managed care to try to move the needle away from pharmacotherapy into psychosocial treatments. So 0 to 6 is a program that we've established in response to the ECSS program that went away about 2-3 years ago. ECSS was a state DHH program whereby there were psychosocial treatments, assessments, and treatments that were being used for 0 to 5. I've increased it by 1 year, for 0 to 5 children, and it was being implemented in 9 different sites. So what we've done is, in the managed care world, things of course work a little differently, and that we don't have providers under contract, but we have to use the systems available. So we've set up a training program with 2 types of evidence-based treatments for the 0 to 6 population: child-parent psychotherapy and parent management training component of PCIT. Dr. Joy Osofsky and the her LSU group trained 2 different cohorts in CPP, and Dr. Mary Margaret Gleason and Tulane colleagues trained in PMT PCIT. We've had we've trained basically 120 providers, enough that we've arrived at what we call geodensity, a sufficient a sufficient number of providers in each region who can provide these therapies. The next step is that we are looking at our workflow, that instead of providing, now we have preferred providers, it's incumbent that managed care use the managed care system to actually develop outcomes that we want. So we're reconfiguring our managed care system such that the preferred providers for the 0 to 6 will get 40 psychotherapy sessions per year per member without having to go through the authorization process. And we're also working on enhanced rates as the contract was to move from into a capitated model. The managed care companies will be in a place where they can enhance rates for some treatments as opposed to others. And because these are so important, we're going to enhance rates. What we're also going to do is then decrease the number of pass-through sessions, automatic sessions that you get for non-preferred providers, because we really want our 0 to 6 most vulnerable members to be in receipt of evidence-based treatments so that there will be less of a need for really for pharmacotherapy for all kinds of less evidence-based treatments. The process is a complicated one, and managed care has a role in promulgating the types of treatments we want to see for specific subpopulations in our Medicaid group. And one of the most vulnerable is the 0 to 6. And so by training in the state and then using a preferred provider list to direct patients toward that group and then measuring outcome and then enhancing rates for this preferred provider treatment, we think that we can move Louisiana away from some of the practices that we think aren't such great practices into practices that I think will have really good outcomes. We didn't do this originally because of ADHD issues. I really started this not only because ECSS was going away, but because of my concern about antipsychotic use in this age group. Another issue that, needless to say, we could spend a day or longer talking about. So that's the nuts and bolts of this. Of course, there are 1,000 moving parts, and the real brains and brawn behind this is Donna Nola Gainey, who's sitting in the audience now. But there are a lot of people working on this, and we plan, Magellan will not be doing the managed care moving forward, but we do plan in the transition to work with the 5 Bayou plans very closely around goals, how we've set this up, and to encourage them to move forward with this, not only for this age group, but for other age groups, other subpopulations that we think really need evidence-based treatments that are not getting them. Thank you.
Dr. Clayton?
We're actually
Hello, my name is Kana Page, and I'm the Director of Practice Management for Metropolitan Human Services District, which is Region 1. And I'm going to talk to you guys about implementing the specialty clinics in the LGE setting. We assumed ownership of the child clinics in 2012. The agency did a market analysis to kind of determine what was available in the city in regards to children's services, and found that there was no major differentiation between the types of services that were being offered. Everybody was kind of doing the same thing. This past year, we've spent a great amount of time working with our 2 schools, LSU and Tulane, and encouraging them or giving them the charge to find out what we can do and how we can do it differently. We wanted to find a niche for us to be able to work with the kids with the severest needs. With that being said, we've worked very closely again with LSU and Tulane, and I'm here with the Tulane group right now to present. And what we've done is we've gone into 3 evidence-based programs that each one of them will present on. But from the LGE perspective, we had to be extremely supportive of what it was that they wanted to do, and providing the staff to be able to do it, and providing the space and changing or rearranging how we had always done things. And so we've gone in from a practice management perspective. We've implemented a new electronic medical record that we've been able to tweak to meet the needs of each one of the programs. And this also helps us out to work with Magellan to be able to provide information and data on the children that we're serving. And I'm going to turn this over to Dr. Gordon to talk about the ADHD and trauma clinic.
Okay. Hello, I'm Dr. Gordon, and I would like to say I'm from Louisiana, so I know the complexities of living in the state and actually practice in this state. I did my training at Tulane and then decided to stay on as faculty in child psychiatry. And Metropolitan has partnered with Tulane to create this program that I'll tell you a little bit about. But I want to tell you my initial reaction, okay? So my initial reaction was, I'm not doing as usual care. I'm not doing community care. I'm actually doing specialization already. But with that being said, when I went to talk to colleagues and people who are doing psychiatry, or particularly early career psychiatrists and mid-psychiatrists, we really were essentially doing the same thing. I mean, maybe some of us were more skilled than others, but we essentially was doing medication management due to the restraints of the clinic setting and not being able to participate in psychotherapy, okay? And so we were asked to create to think about what our clients needed in the clinic that I work at, Metropolitan Charters Clinic, and see how we could, do something different. So initially the reaction was, well, what about the kids who we already have, we've been seeing, and they're doing great, and we want to keep doing things the way we are, and which kids did we pick? So we decided to do an ADHD clinic, a trauma clinic, and as you guys know, Louisiana ranks high really with post-traumatic stress disorder and mood disorders, in addition to, our as usual care, our lanyard clinic for kids with autism and, psychosis and bipolar, those things that we all love to treat. But I'm going to talk about the ADHD clinic today because I do most of my supervision in that clinic. So the complex ADHD clinic was designed in a way where we could start doing our evidence-based therapies for all the clients. And some of you guys who practice and know how difficult it is to get therapy for kids. So we decided to do a group therapy approach, group therapy intervention, which put a task on the psychiatrist because we had to give up some of our time so the patient could get some therapy, okay? And so we decided to have our medication management be 15 minutes and the patients to get a therapy, an hour therapy when they come to the clinic, which for me was, oh, wow, I've got to, train residents to be able to do 15-minute med checks. And I really don't want to do that because, what are we saying if we're giving kids 15 minutes to do med checks? So we decided to do it with thoughts in mind. And basically we wanted to do
what you should be doing ADHD. Work with kids with their social skills training, anger management. Also, focus on school advocacy and school-based interventions. So we decided to do it in a group format where the parents will get their own training in how, to manage an ADHD child, how to manage the school system, and how to manage co-occurring disorders. We didn't want to exclude kids who had other co-occurring disorders. So we have a complex ADHD clinic. So most of our kids, as you know, ADHD is typically comorbid with ODD. So most of our kids are complex ADHD kids who have tried treatment in other settings like MHRs or community care and haven't been successful. But I mean, the tremendous need, the parents are very excited about it. I mean, it's fascinating. The kids not so much because they're not used to being in the, the ADHD kids was first thing in the morning or in the afternoon. They're like, almost done with school. But the parents are really loving and enjoying it. And the medication management is actually more productive because they're coming in and they're talking about what's happening with their kids at school, what their kids' grades are. I tried this reward system and it's not working. So, I mean, I think it's been pretty productive. I would like to say from a minority who's working in a, predominantly minority area in Orleans Parish, there's a huge need for trauma therapy. And so in addition to that, we wanted to make sure that we include those kids for trauma therapy. And what's interesting is the parents are coming in for ADHD management because the school, is asking them to come in for ADHD management, but not so much for trauma therapy. So that's something that we think about ADHD treatment. Are we treating kids for ADHD or are we treating for other things too? And I think that's the question that we're asking and we're doing. We're getting pre and post data, so we're monitoring regularly their ADHD scales to see, how they're doing in their schools. And we're actually seeing some positive outcomes. I haven't looked at all the data, but so far I'm really impressed with the changes that we've had in a short period of time. We initiated this, I call it pilot program because we'll see how it goes, but in September, and it's been great. I'm trying to take my time because I could just 1 minute. Okay. So I think the other component to it is actually that we initially thought we would do this for a 6-month cycle. So they're scheduled for appointment once a month. They come in, they get their med management, but they also get their therapy. But that, looking at it now, it seems like a little bit more is needed. And what we proposed to Metropolitan, and we're working on it now, is a resource center for families. So when they can come in and get resources, even when they don't necessarily have appointments, they can come in and look up school advocacy things, have computers, and some things that's not available to some parents. And also have lifestyle groups that we haven't started yet, but getting volunteers from the community, particularly college students, to come in and mentor and be peer advocates for students. And I think that's really, really important. We want to have a community-based intervention and to meet people where they are and strengthen families. And I think it changes the climate of a clinic when you're prescribing medications and that's all you're doing, or when you're doing therapy and you're asking them, how things are going. And so we've been seeing some positive results there. And I'll stop now and give Valerie.
Hi, I'm Valerie Rada-Johnston. I'm the psychologist at the Metropolitan Clinic along with Kim. And I'm sitting here smiling because it sounds so nice and neat, like, oh, and then we did this, and this is fine. But what we're leaving out is the hours and hours of banging our heads on tables and tearing our hair out and trying to come up with actually what's going to work. The parents are responding really well to the groups now. The first week, the first month, it was week after week of, why do I have to sit in this group? And I'm not the one with ADHD, although some of them do. Why am I in a group? And I did all of the parents' groups for the first month. So I got to see every single parent. And what I tried to, my basic line is, this is not a touchy-feely, share your feelings with the group and we're all going to hold hands afterwards group. This is, ADHD kids are hard. Kids with ADHD and something else are hard. It's hard to be a parent. It's hard to be a parent in our area. Things are hard. So how many tools can we give you to work with? Because if something doesn't work, let's try something else. And they warmed to the idea. They were not loving it. Some were. And especially when I said, I'm going to come in with, and my interns or the psychiatry residents or the psychiatrists or the social workers, we're going to come in with an agenda for the parents, but you guys are adults and you have things that you come in with. So what we do in this group is going to be also guided by the parents, and that helped tremendously. So the way that the groups are structured, I'm going to start with the parents group. We let the parents know what the kids are doing in their group first, so that when they go home, they can help their children practice that for the month. For example, the first month we taught the kids how to do belly breathing or deep breathing and when it could be used. And so I sat in the room of initially irritated and angry parents, and we did belly breathing, which actually helped, and they started laughing because, wow, that felt good, and actually that kind of made the hour worth it. So we do exactly with the parents what the kids are doing in their group. Then we give them some tools, some parenting tools. So it might be things as basic as labeled praise. It might get into more complicated things such as how to do a reward system. Sometimes we have to go back to basics of what's a privilege, what's a right, and what's a reward, and you know, that you can say no and all of those things. And all the way through, so we have the topics divided up from starting out with what is ADHD, all the way down to how do you advocate for your child in a classroom situation, in a school situation, even in sometimes a psychiatric situation. How do you talk to your psychiatrist about this doesn't seem to work? A lot of times we get about halfway through and it kind of develops into school problems, because that is the major area that our kids are having repeated problems in, even if they're doing better. So our kids very often are making improvements, but they're still the target kids. And just having someone else, someone in the clinic say, yes, your kids are targets in a classroom setting, that you see them relax. And it's like, okay, you get it. Yeah, our kids have been labeled since early Head Start that they're the kids with ADHD and they're going to be the ones who are doing things wrong until they graduate from, you know, a PhD program. For the kids, so let's switch over to the kids real quick. For the children, what we do is a basic coping skill every week or every month. They come in once a month. So the kids do belly breathing. We've done progressive muscle relaxation. We're starting in on mindfulness training next month. So they have a series of mindfulness exercises that they're going to go through in group. Now, do all the kids with ADHD first thing in the morning or at the end of the day rolling, going, oh, I'd love to spend one more hour having somebody teach me how to do something? Absolutely not. They roll in rambunctious. But the kids have, they are absorbing things. After the parent group, I'll kind of hang out in the waiting area, and I'll ask the kids, how was group? And they'll say, fine. And then I'll ask them, what did you do? Nothing. And I'll say, oh, well, what kind of nothing did you do? And then they get exasperated, and they'll say, we did belly breathing. And I'm like, oh, well, what's that? And then they tell me the whole thing, and their parents sit there with their jaws open, like, wow, he really picked that up. And the kids are going home and practicing stuff, and the parents are going home and practicing the things that we're giving them as well. It is a big time commitment for the parents. It's 2 hours instead of 1. So everyone gets there at one time. Half the group goes into groups, and the other half is their med management. And then they flip. The people who just did med management go to groups, and the people who are in groups go to med management. So it's a time commitment, and that is probably our biggest struggle. Especially if kids get to be doing better in school, then the schools don't want us to take them out. You know, wow, we've seen improvement, now go away. But they're not going to continue to have that improvement if they don't finish. So it becomes a struggle. I think that's my time, so pass it on.
Hi, I'm Mary Margaret Gleason. I'm a child psychiatrist, pediatrician at Tulane, and I wanted to just take a moment again to thank Kristen Savicki and Heather Taylor for organizing this, because the fact that this room is full and there's another full room and there are people on the web speaks to how important this topic is and the great job they did in organizing. I usually, when I start talking about the early childhood clinic that is a partnership between Metropolitan and the Tulane group, I usually have to give a rationale of why do we need to talk about early childhood mental health in an ADHD conference. And luckily, Dr. Visser has done a fabulous job of highlighting the prevalence and the importance, the functional impairment that goes along with early on ADHD early on, and the conundrums we have in treatment. So I think that that is the rationale for why our clinic exists. In working with Metropolitan, I should say LSU has a parallel clinic for young children that works quite similarly. And so in Orleans, we are blessed with many more resources for early childhood services than most people around the state, and feel very lucky about that. The clinic that the process that we have is under the umbrella of Metropolitan, and we moved physically to the clinic space in May of last year. I want to highlight one of the parts of ADHD that we haven't talked about quite so much today, that both the LSU clinic and the Tulane clinic do extensively, and that's assessment. So we see children 0 to 6 who are Medicaid eligible, who live in the catchment area. The chief complaint when we ask them on their initial intake is 80% behavior problems. Some endorse other problems as well, but 80% of the families coming in endorse behavior problems. Starting right there, if you only have 10 minutes, 11 minutes in a primary care session, that's going to be ADHD. That's sort of how that process works. Or it's going to be you're under 6, come back when you're 6 and I can deal with it. That's because there's not the capacity to do an evaluation. What we do in the early childhood clinic is an extensive evaluation of the child's symptoms and also the child's context. So the first appointment is finding out about the symptoms, the concerns, more traditional history of family history, medical history. The second appointment is a parent-child interaction procedure. So we look at the caregiving context. Parents are the most important people in a child's life. So we have to understand the strengths of that relationship and also the vulnerabilities so that we can shape the child's caregiving context to promote health and well-being. We may also do another appointment focused on the parent's perception or understanding of the child. So really, by the time we get to a full evaluation, we may have spent those 3 appointments. We probably have gone to the school to observe the child in that context because young children's behavior is so context specific. We want to understand the multiple contexts in which a child lives. And after the assessment, what we find is only about 30% of the children referred to us have ADHD. And I wanted to highlight that process because not all systems support that many evaluation appointments. The 0 to 6 program through Magellan, I think, is a fabulous way of making sure that young children can access the kind of evaluation they need so that we can give them the treatment for the disorder they have or the context in which they're living. The treatments that we do, we have a team of psychologists and child psychiatrists as well as a case manager who does great work with the families. Valerie is one of the psychologists on the team, and we have multiple trainees, psychology, triple board, which is pediatric psychiatry and child psychiatry, and also child psychiatry. We have been trained in parent-child interaction therapy, and that's one of the most common treatments that we use, especially for those children with ADHD. Our team also has expertise in child-parent psychotherapy. We have people who've been trained in a really nice model called Circle of Security that addresses parents understanding the cues that their children give. And we also have extensive experience with preschool cognitive behavioral therapy for trauma. So we use evidence-based treatments in this program, but we make sure that we understand what we're treating first. There are children who receive medications in our program as well. It's a small number. It's calculated probably about 20%. And so I personally contribute to some of those numbers, but not at a huge rate. And what we see in following up outcomes, and these data are from ECSS, not from TIMS quite yet, is that the symptom reports from parents go from the high clinical range, 97th percentile, down to the 67th percentile. So we're going from significant problems down to what's considered typical range of parent-reported problems. That's using a model that's quite similar to what we're doing now with the same population. So I expect that we'll be seeing the same findings when we get to do our evaluations. I know I'm almost done, but I wanted to loop back to say that the partnership with Metropolitan is so critical because we need to have an infrastructure for collecting data. We need to have an electronic record that provides this kind of information. And I really appreciate the quote of looking at the need to look at outcomes rather than the intent, because intent only gets us so far. So I'll finish there. And
hi, I'm Allison Booth, and I am at Tulane. I'm a clinical psychologist, and I direct some early childhood mental health consultation programs, one that provides services across the state to child care centers, and another that works in New Orleans with charter school elementary programs, so pre-K through second grade. And I'm going to switch the conversation some to looking at how schools, early education in schools, and parents can support the environment to support children at all levels of attention. So looking really at self-regulation and attention and how we can support that growth in young children. And when we think about ADHD, it's really easy to just focus on the attention and the hyperactivity, but I'm going to have a look more at the underlying deficits in self-regulation and how we can support that. So I'm going to just briefly go through 4 things that we work with early education environments and sometimes parents on helping them to change these for their children. And the first is environment support. So we really want to look at, does this environment support self-regulation and development of self-regulation? So are there visuals posted for children? We definitely see this in the school system and in some child care centers, that there are schedules posted and maybe rules posted, hopefully rules that the kids had a role in putting together. But we also need teachers to refer to those schedules and refer to those visuals to help children know where they're going throughout the day. And probably everyone in this room has a schedule either on their phone or in an agenda, and you need that visual reminder to know what you're doing during the day. Our children do too, and it's a way to model for them self-regulation and how to set their day up. We also have to think about externalizing motivators. This is particularly true for children who have attention difficulties. They need to have a visual reminder that after I've done this, I get a check, and that check motivates me. I can earn something for these 3 checks for this sticker. Maybe I get to earn a preferred activity or some small trinket or toy. While some teachers say, I don't want to create a bunch of sticker junkies, and I understand that, we hope that children will be able to internalize this motivator over time, but to start, we have to externalize it for them. And we also have to break the day up for kids. I kind of think of it as children have a self-regulation tank. And if they have lots of teacher-directed activity after teacher-directed activity, that tank's going to be depleted, and they're just not going to be able to keep that self-regulation together. So we have to break that up and give them active learning in between those teacher-directed activities. Our parents are taking kids to church and then expecting them to go to Sunday school and church. Maybe they need to go outside and play for a little bit in between those so that they can self-regulate throughout those couple of hours. We also want to think about exercise. So I think someone else is going to talk some about exercise, but there are definitely studies out there telling us that exercise improves self-regulation. So we need to make sure that all of our children have adequate opportunities to get out and exercise. Some of the schools that we're working with, first grade maybe has 10 or 15 minutes of recess during the day. And we're thinking with them about how can we increase that. So how can we make sure that PE is happening and there's self-directed time that kids can really blow up some steam and move around. I've seen this really work. In that same first grade classroom where the whole class only got 15 minutes, there were 5 boys who were all diagnosed with ADHD, and the teacher had an assistant who was able to take those kids out and have them run around for about 10 minutes in the afternoon. And they were able to sit and learn for the rest of the afternoon. When that assistant wasn't there at the end of the year, she had about a month where things looked very, very different because there wasn't anyone to let those boys go outside and run. Highly, highly important for them. And then we have to intentionally teach social emotional skills. We intentionally teach academic skills. We don't always intentionally teach social emotional skills. So one way to make this happen in schools is to have a social emotional curriculum that we use. This lets teachers know that the leadership thinks it's important, and it helps build time into the day. One that we work with a lot of programs on using is the PATHS model, which is promoting alternative thinking strategies. And I really like it because it doesn't take a lot of time out of the day. It can be done 3 to 5 times a week for about 15 minutes. And there's some good outcomes. Kids are doing better afterwards. They're able to solve problems. They have increased self-regulation. And they have increased cognitive skills as well. And finally, we need to support kids in real play. So in kids imagining, working with their friends to figure out what game are we going to play, what role are you going to take, and then staying within that role. When children have to stay within a play role, they have to inhibit the doing other things that doesn't work with that role. So if we're playing house and I'm the mom, I have to act like a mom. I can't suddenly start drinking out of the dog bowl unless I talk with my friends about, okay, now I'm going to be the dog and I'm going to get to drink out of the dog bowl and bark. And you're the mom and you're going to tell me what to do and feed me. And when kids are in play situations, they show advanced levels of self-regulation. So one study looked at kids and said, we need you to stand still as the lookouts. This is a secret spy mission and you are the lookouts. Kids at age 5 were able to stand still for about 12 minutes on average. When 5-year-old kids were asked to just stand still for 5 minutes, they stood still for 4 minutes. That's a big difference. But kids aren't getting the opportunity to do this imaginative play, and when we have when we look at children who are playing today, they're actually playing at lower levels than is expected. So we know we need to teach kids self-regulation. We need to support their imaginative play so they can practice self-regulation. And then if we put this all together, we can have environments that support regulation, we can teach self-regulation, and hopefully kids will be able to progress to the level they should be. My final point is there was a study done in the 1940s looking at self-regulation of 5-year-olds and 7-year-olds. This study was redone in the 2000s. And the 7-year-olds in the 2000s helped the self-regulation of the 5-year-olds in the 1940s. So there's so many intrusions of young children's time today that takes away from self-regulation practice opportunities like television, like overscheduling. There are many, many things, and we need to support and protect that play time and that social emotional teaching time. Thank you.
Good afternoon. My name is Holly Pazak. I am from the Human Development Center housed within the LSU Health Center in New Orleans. When Dr. Vicky contacted me and we had conversations, and I told her a little bit about what I did as an educational consultant in the New Orleans Type 5 charter schools in particular, I told her, I said, hey, we work with all sorts of students, students with disabilities, students without, students with ADHD, students without. And she said, you know, that's great. Just speak a little bit about the work that you do in schools and how it encompasses that broad level of support in what we do. So we primarily, my group, Teams Intervening Early to Reach All Students, or the TIERS group. We are school psychologists by training, but do a lot of systems level capacity and building and support and technical assistance with primarily the Type 5 charter schools, RSD schools, in New Orleans. We do work outside of Louisiana and other states, but I'm going to talk just a bit primarily about our work that we do within the New Orleans area. We also work in conjunction with the Louisiana School Psychology Internship Consortium. We have a group of school psychology interns, APA accredited internship site, and we are available to provide schools within New Orleans a school psychology intern, and so they can see the types of supports and services that they can do, primarily helping those kids with and without disabilities. So the morning started out, you gave us kind of a charge to think about assessment, treatment, and then family partnerships. And so I'm going to talk a little bit about the assessment piece that we do in the schools. I'm going to talk about behavioral supports and interventions, and then family-school partnerships. So when we work with schools primarily, building that level of support and capacity, we ask a little bit about data, right? What kind of data do you have? How is that driving your decision-making, your instruction? How is that driving your supports? So we talk about universal screening data, looking at kids who might be at risk of showing some of those internalizing, externalizing behaviors that we see in school, and that helps us better target kind of how we can provide those children support. How can we give them interventions? Not only that, we implement what's called tiers, multi-tiered systems and supports, which is increasing your interventions as you go along for those kids who need it. And when we implement those interventions, we take data as well. It's not enough to say that you've given them something or, hey, we're intervening, but is that working? How are we evaluating the outcome of those interventions? That's progress monitoring data that we use. So when we work with schools to set up systems, we ask that first question. What do you have? How do you know what's going on? How do you know who to support and who not to support? Let's look at that data. And then as far as setting up that continuum of behavioral and supports, we do some of the things that you discussed. You know, we look at that screening data. We ask about a behavior curriculum. Okay, how are you teaching rules and expectations? Do your kids know what your rules and expectations are? We have some schools that the first month of school, that really, you know, tumultuous time when everybody's getting back into the routine and, you know, what is it that we need to do? We have schools that set up a schedule. They have a rule per day, an expectation per week, and they explicitly teach those rules and expectations. We teach academics, right? How do you do math? How do you read? How do you write? But a lot of times we don't have that explicit instruction in behavior, and it's really critically important. So we work with schools in building those systems up. Social skills training, we help schools formulate social skills groups based on the data that they have that these kids need. We have schools that we work with that they have a lunch group for kids that have been identified 504, some of them with ADHD, some of them with not, but they work on kind of executive skills throughout the week. They have graphic organizers. They look at self-monitoring tools. They look at their assessments and their grades. And so that's just one way that we have a school that's kind of working with that population. Relationship building with families, systems of reinforcement, those type things. We also have schools look at their policies. Discipline policies are, do they have policies that systematically lend themselves to excluding those kids that have been identified with ADHD, been identified with disabilities, rather than supporting them. And finally, we work with capacity building, integrity, what we call integrity of once we put things into place, once we're building those systems of support, are we checking to make sure we're actually doing what we're supposed to be doing and making decisions upon that data, and working with schools to help build better family partnerships, not always calling home with the bad news, but calling home with the good news, and how can we further those relationships and really build that support. So that's just a brief snippet of what all we do, and it encompasses a broad variety of things, but we think it's important work, and we enjoy being in the schools and helping our school staff and teachers really support these kids that need the most assistance and help.
All right, I'm going to go off script and steal for my own 6 minutes and ask everyone to stand up for a second. So everyone, as long as you can do it safely, you're not going to run into it. Just stand up for a second. And, I'd like to ask you to jump around and stuff, but I'm not going to do that. But we've been sitting for quite a long time. Everyone's doing a great job paying attention, and it's pretty fabulous. But I just want you to tune into how much sitting for such a long period of time, how negative that is, how toxic that is for your body and for your brain. And so, part of what I'm going to talk about is exercise, and we can just tune into ourselves and realize when you sit for long periods of time, your brain goes into rest mode. It's really easy for you to turn off. You don't get your blood pumping back up to your brain as well as you do when you sit. And so as much as possible, when I hear kids are running around too much, I just always say to the parent, it's better than sitting. It's better than sitting. So I'll let you all sit back down. So I'm Chris Levy. I'm a psychiatrist at LSU, and I work in primary care clinics, which are mostly federally qualified health centers, which are mostly Medicaid kids, and I'm there seeing, first line, how our kids are, with the kind of typical presentation for the typical kid in Louisiana, I think. And then I work in juvenile corrections also. So I see kids down the line who have sort of failed on a number of levels. And so while I do work at LSU, I do a lot of teaching. I'm not an ivory tower child psychiatrist. And I'm going to, once again, I do always go off script a little. I think in some ways we have to blow up the idea of ADHD in order to save it. I think kids that are very severe and have severe deficits and clearly are struggling to function, that label, fits well for them, and we need to have labels. Labels are very important so we can talk to each other about what's going on with these kids, and we can put them in groups, and we can kind of understand, what treatment might work. But we have to also step back and say, when you got 80 billion plus neurons in your brain, and you're taking 6 symptoms and clicking often on them, and that's how you come to your diagnosis, let's be realistic about what we're doing here. So, while we've invested a lot in this model of ADHD, it is a very primitive model. And the more you talk to researchers and scientists who really study it, they don't use this model. This is not how the people who study how the brain works model the brain. So that's the first thing that I would emphasize, is we have to step back and make sure we're not making model error, systemic error about how we approach these things, and therefore leading to what I would say overly simple solutions to incredibly complex problems. And if you listen to all these panelists, what they have to say, there's a lot of wisdom here about how we can help kids do better. There's a lot of ways. There's a lot of broad solutions. And if you look at, which is what, from my experience being a child psychiatrist and going to all the meetings, it gets much, much more complex the more you know about it. And it gets really confusing. And so what I thought is, what makes the brain work? What is going to make the brain work? Can I break it down to the most simple components of what helps a brain function? So number one, I thought, eat food. What powers our brain? What are we supposed to eat? We are not supposed to be eating factory-made food-like products. That's not what helps the brain. And there's significant evidence. It doesn't fit the paradigm. It doesn't fit with the, what drug companies want us to fit, but the evidence is really good. How does the fish oil, after a month, start in a blinded placebo-controlled study being picked out as helping the kid? If fish oil, so in some ways, by fish oil working and being, even though the effect size is less than medicine, it's just good for you, right? So if it works, to some degree, ADHD is a nutritional disorder. And we need, our brain is 60% mostly fat. It's of all the organs in our body, it's the one with the most fat. We need to get the right kind of fats in it. We need to have processed foods out of our diet to the degree possible. So if we can eat food, meaning things from trees and out of the garden, we are going to help our kids do better. And we should try that. We need to get them off of the toxic foods like the Trix and the Fruity Pebbles and the sausage on a stick before we give them a medicine. Why would you give them the medicine first? The second thing, kids need to get up and move. Like I said, there's all sorts of evidence that the brain works better when you exercise. You get better grades. You have less behavior programs. There are places where they've gone into schools. They've done these programs. They absolutely work. We need to be doing them, and we should do them. And who benefits the most? The high-energy kids and the kids that are not great scholars. Those are the ones that are going to like these things the most, and they're going to feel more at home. And many of the kids I treat, they hate school. By second grade, the boys hate school. And you look at our numbers about how far behind our boys are, our girls, Louisiana is an outlier state with this. We're worse. It's true that in every state the boys develop later. But we are an outlier. We're failing our boys. Our schools are hostile places for them, and we need to change that. Honoring silence is my third rule. You cannot take in 10 hours of media every single day. Okay, they multitask it into 7.5. But it's 10 hours of media. That's average for an American kid. In Louisiana, the studies show if you have a TV in your room, you're more likely to have cardiometabolic signs of heart disease as a kid. And those are Louisiana kids. We've studied it. When you have a TV in your room, you get about 30 minutes less sleep per night every single night for your whole childhood. So there are interventions about the media and about changing the ecology that children are, that I believe are much more powerful than giving them a medicine. If you get the TV out of the room of a 6-year-old, that's going to help them more than putting that kid on medicine, right? So there's many things we can do. And the problem is, of course, as everyone here has said, these are family, social, cultural issues. They're very complex, and you have to meet people where they're at. Not everyone is in change mode. My belief is that we can do a lot better with emphasizing what makes a brain healthy, which is enough sleep, self-care, meditative processes, exercise, and then also eating food. So there you go.
We've got enough time for just a couple questions before we give instructions on our breakout groups. So remember, you need to speak into the microphone.
What electronic record is LCE using?
We're using CareLogic.
CareLogic. Qualifax CareLogic. A couple more questions for the panel?
This is for Dr. Dalton. Are you all training any more providers to do the parent interactive therapy for 0 to 6?
We are going to train, we have one cohort, parents
You got to get.
We have one more cohort of training in child-parent psychotherapy, and then that will be it. Now, we'll be talking with our Bayou partners about this program, so hopefully we'll see more of it in the future.
I believe this is for Dr. Booth. Which universal screening are you utilizing for the assessment center?
That's actually not for me, but
I may be able to answer it. We'll, for the launch program, we'll use ASQ and then the EXA, which is the Early Childhood Screening Assessment.
Okay. Anyone else? Raise your hand. Great. Want to thank the panel. Very, very good evidence of some of the great work that's going on in Louisiana to help kids and families. It seems like there's a lot going on in the New Orleans area, so if we can get that spread across the state, I think that's one of the solutions that sit in several of your heads out there. So next we're going to move to our breakout groups. This is a very, very important part of the day because we have so many people. We have folks in the other room, we have folks on the internet, we have folks on here. Folks on the internet, any ideas you have, type them into the internet. We're going to be back with you about 3 o'clock. For folks in the room, we're going to have 3 breakout groups. You should have received your breakout group number on your green folder or your yellow folder when you first checked in. So take a look at that. If it's not there or if you're having difficulty seeing it or whatever, if you're a prescriber, you're going to be going upstairs with Dr. Hussey. Raise your hands. Dr. Hussey. He's going to take you upstairs to room 673. If you are an educator, you're going to be coming with me, and we're going to be going to room, oh, we're in here, that's right. And then if you are a, what's the other group, behavioral health providers? So if you are a therapist or if you are somebody who's doing some sort of mental health, behavioral health, you're going to be going to room, what's the number? 173, which is on the other side. Now, before you go, we got to give you some technical assistance around how to be a good group member because you have lots of you. We were going to be problem solving around 3 areas. How to screen, how to improve screening and assessment for kids with ADHD. How to better treat, which includes psychosocial treatment, coaching support for family members and kids, and prescribing. And then how can we support kids and families who have ADHD? There's a lot of educators in the room. How many teachers do we have in the room? Do we have a couple? They need our support too. That's the behavioral health, that middle area, where that bucket. We're going to try to be helping them with how to manage kids in the classroom, guidance counselors, that sort of thing. Solutions are like this. We need to provide more training to teachers. That would be a solution. A war story is, oh, I had this kid, I'll tell you, they were the hardest, and then we did this, and then we did that. That's not a solution. That's a story, and stories are great. They're just not here. So before you speak, format what you're going to say into a solution, a very simple statement of what could help moving forward, because we're going to take these and use them moving forward to fundamentally transform how Louisiana provides services to this population and their loved ones. So if you have any questions of where to go, speak with me. All right, everyone. Come on back. The webinar is back on. We've got our friends in cyberspace with us. Let's get going, everyone. Well, we had very lively breakout rooms. Mine was lively. Dr. Dunham said hers was lively. Where's Dr. Hussey? Is he here? His was so lively he hasn't even gotten back to the room yet. So we had some breakouts, as we said, identifying different solutions. Carl Sagan said that shh made people quiet because it was the sound of large predators breathing. It seems to work. Works in your classrooms too. So we just went through what oftentimes feels like a little bit of a cumbersome, sloppy process of getting groups of people with committed visions for how Louisiana can improve on providing services to these vulnerable populations. How to get those committed stakeholders, you all, to come up with some solutions. And we were able to come up with many, many solutions. We've got a task force that has been assigned by the legislature, which we see as a real opportunity to actually bring to bear some of these solutions you all have put on the table. Narrowing down the solutions is often the difficult part, because if we can get those solutions and formulate those into a vision of how Louisiana can look different when it comes to screening, assessment, treating, and supporting social service agencies, parents, and kids with ADHD, if we get a clear vision, then oftentimes you can take that back to the legislature and actually get that funded. So what we'll be working on this afternoon is to identify the major take-homes from our solution list. However, we will capture every solution that was put down on the easel paper, and then we also had people taking notes. So we had ghostwriters in the background capturing information too that you all mentioned, so that we wouldn't lose anything. We're going to do a quick report out from each group right now, and then the task force is going to take all of your solutions and whittle them down into theme areas and break them into some potential next steps for you all as the leaders. As I mentioned to my group, leadership isn't something you're born with. It's not something that's given to anybody. Leadership is about showing up and saying, I care about this and I want to support a solution to this. And that makes all of you certified leaders right now. So we will all be coming back to hear from you, and we all want to hear from you in the form of filling out this card. So before we do a report out, we want to make sure you guys are aware and have one of these cards, and I'm going to explain how to fill it out right after our report outs. But if you don't have one of these cards, raise your hand. They'll come around and give you one, okay? It's very important you get one of these cards, your leadership card, I'll call them. So who wants to report out first? Dr. Hussey, Dr. Dunham? All right. What did you learn?
Oh, I learned a lot, and some of this was really thematic, which was very interesting. So we divided ourselves up into 3 groups. One group tackled the subject matter of evaluation, how to be more effective in evaluating, the other one treatment, and the other one did how to engage parents. And so there were some things that were thematic and cross-cutting for all of those groups, like timing, for example. It's pervasively relevant. That timing is appropriate in terms of being given enough time to evaluate, which evaluations typically are thought of as being done in one setting. But the reality is you don't get to know anybody in one setting. You know people over multiple contact hours. And so using the time to do that, but also having the time to work with families is also important. And then once you establish what the issues are, having the time to actually deliver the services over a reasonable period of time. The other thing was having services that are culturally relevant on all 3 accounts, as well as being age appropriate in terms of how we evaluate and how we deliver services and the things that we do for family members who constitute the entire unit. The whole wraparound model is also thematic in that we really want to engage multiple partners, because the child is identified as the patient, but we know that there are multiple individuals who touch the life of that child, and if we're not bringing together all components of that unit in our evaluation, treatment, and work with families, then we're going to fall short in terms of getting at what we're really trying to do. And we're talking about alternatives to medications from a behavioral health standpoint, so training is very, very important. The whole concept of trauma is one that we touched on. Trauma is pervasive in our population. In fact, it's probably the most underdiagnosed condition for people who we see in behavioral health. It's ironic, I think, that even though we see people who, in many cases, 70 to 80% of whom have a diagnosable traumatic condition, we as clinicians are not very well trained to treat those, and so we engage over and over again in re-traumatizing the very victims who are seeking the services from us. And so that was thematic in our group. Motivational interviewing, knowing how to position yourself and frame the evaluation, the treatment, and the work with families in such a way that you actually inspire them to give you the information you need and to cooperate with you. on the evaluation level, but motivational enhancement treatment is the corollary to the interview that allows for you to get to the interventions that you're putting in place. The other thing we talk about is empowering parents. Parents, at the end of the day, are really the ones who have the power. We really don't. We live in a fallacy of thinking that we are the most knowing and the most capable, and in truth, the power really does not reside with us. And certainly for a child, we don't have any power. It's the people who are rearing them and actually are providing them food, clothing, and shelter. And so allowing parents to understand what's available to them is wisdom at its best, making sure that they have access to everything that they need so that they can be good participants in this process is important, empowering that's necessary from a behavioral health standpoint that has nothing to do with medication, but it's something that we can do a lot more work to develop skills in. We talk about technology and leveraging technology much better in order to do a better job at assessing, treating, and helping parents. There was a suggestion of a website that parents can go to for apps, for instance, that they can access. Mindfulness apps was one of the things that one of our participants recommended. Mindfulness therapy, by the way, was also something that was mentioned. I think it was mentioned as a part of the discussions during the day as well. Of course, there are a lot of barriers, and one of the challenges for the group was as you think through what can work, also think about what can impede its progress. And so there are managed care issues as it relates to funding. We talk about time, but time is an enemy almost of managed care. And so how do you deal with that? How do you put in place the right financing structures, the necessity requirements that allow you to leverage what you need in order to actually compensate for the services that are needed? We talk about training and the need for people to be adequately trained, and perhaps even developing a creative compensation strategy for those who have higher training, being able to build a different coding system and be paid a commensurate reimbursement because of that enhanced knowledge. For parents in particular, we also talk about help lines for parents and strength-based models to help them to know how to approach their children. A lot of these things were said in the meeting, but it was interesting that as the various groups reported out and talked, again, a lot of these things were cross-cutting. We also need to, for treatment, look at a cross-systems initiatives, because just as there are multiple units, multiple components of a unit that constitute those who directly influence a child, external to that unit are multiple systems that influence our capability to effectively leverage what we need in order to impact the child and the family's attempts at improvement. And so policies, we all talk about evidence-based practices. Evidence-based practices become our nemesis at some point because there are fewer of those than there are relevant things that we can do that don't have anything to do with research necessarily, like respecting the knowledge of parents, respecting the knowledge of the children, engaging them appropriately in the determination of what's important for their own change. So these are some of the things that we talked about, Jeff. The list goes on, but I just wanted to give you an encapsulation of where we were, and the full listing we'll have available for you.
Thank you. Dr. Duff, do you want to go or you want me to go? Or do you have to go?
Our group, we split it up between Dr. Dalton, facilitating the prescriber group, and Dr. Walker doing the managed care, so Dr. Dalton.
So we had a very lively discussion, and I think a very timely one. The issue where I was working with the prescriber group, and I think everyone in the group recognizes the importance of evidence-based treatment and really evidence-based assessment and getting your ducks in a row. And the group listened quite well to the panel, and especially the members of the panel who were discussing psychosocial treatments and how you integrate psychosocial treatments into busy practices. And I think where the rubber hits the road, though, is it's a little different for primary care providers, for pediatricians, than it is for, I guess, for specialty providers, child psychiatrists. But as it all pans out, it actually looked similar. The problem is when families come in and they're under the gun from school and from various settings in which the child is presenting with ADHD symptoms and maybe developmental behavioral disorder symptoms, how do you slow the process down, especially when you're in a busy practice where you have 15 to 20 minutes? And we're saying that good assessments take time. How do you introduce to the family that you recognize and you certainly want to validate their concerns about their child's behavior? At the same time, you want to slow the process down so that the family doesn't leave the first 15-minute session with a prescription. And that's not so easy to do. I mean, it's easy to do in that you could just say no, but it's not easy to do in a way where you develop an alliance with the family, get them on board for the hard work that is to come, that isn't just about prescriptions, and yet they're under the gun to change behavior and do something now. So we don't have the answer to that, but we grappled with it and talked about it in a way that made it clear that the knowledge base that we have about what works and what doesn't work has to be applied on the ground in real time as it's happening. And the truth is that that's not so easy to do. And so one of the things that I take out of this is the need to connect what we know works with expectations of families and the community when they come to us in the managed care world in which we live, which is a pretty quick world. And how to make all that work, that soup, work in a way that on the ground is meaningful for kids. So with that context, we talked about assessments, screening and assessments, education, and treatment. Screening and assessments, it seems clear that clinicians have to use as just the basis of things an instrument, a psychological instrument, a rating scale with good psychometric properties. And a number were discussed and they all sound fine to me, and there are a number of them out there. But in addition to that, I think clinicians also need to use a broadband rating scale that will help not just clarify whether ADHD symptoms are on board, but what else might be on board, the comorbidity side of this, especially around anxiety, the PSQ-17. I mean, there are a number of broadband instruments out there that are very functional and very useful. But those two alone aren't enough. I mean, that's just the beginning process, and that's really more the, if not screening, early assessment part of this, that you really have to do the old-time religion, which is spending time with families and children, talking about issues, trying to understand pressures, trying to understand what one's life really is, trying to understand how the ADHD symptoms present in the context of the individual's life and the individual's family. And there's no shortcut to that. And so I recommend, and this is just me talking, I said this in the meeting and everyone said, but I think that the deal is that you don't want to give a prescription after your first visit. I mean, you just don't want to do that. I don't particularly want to do that after the second one either. There's a lot of pressure there. And having to finesse that approach with family expectation and with their genuine concern about what's going to happen to their child, that's not easy. And that could take the 15 minutes itself. So there's no real answer to that. The second is the education side. And it's very important to educate families not only about ADHD, not only about the pressures they face, because they already really understand that, but also about therapies, about approaches. I think this is a very important thing to do, but I don't think it's so important that you put it at the top of your list. I think education always is helpful, but it's really something that works best in the context of when you have a relationship with the family already and they're not so anxious about what to do this very minute. And the third thing is treatment. We listened well to the panel, especially the LSU folks and the Tulane folks talking about their experiences at Metropolitan, where they are reducing the med management time frame so that patients can have an opportunity to also be part of a psychosocial group treatment. And the psychosocial group treatment isn't just talking therapy. It's a treatment that has specific components to it that the components themselves will lead to change over time. It doesn't happen immediately, we know that. But it's really important whether you're in a private practice primary care setting or whether you're in an LGE, Human Service District, mental health center setting, to find a mechanism for that. The group therapy approach discussed by the panel won't work in someone's private practice office. But what would work in the age of managed care is bringing in a social worker or a counselor into, not into your practice, someone you have a business relationship with, but someone you bring in so that he or she can, if you've got 45 minutes with a child, you take 15 minutes, especially this is with someone whom you know, it's not with a first-time patient, obviously, but you take 15 minutes doing med management with the patient who you know, and then half an hour with the social worker, with the psychologist, with the counselor, talking about the issues that are really important and that will make a difference in terms of long-term outcome. The current way in which we're delivering ADHD services, and there are lots of forces that come together to make this work the way it's working, but the current way we're providing the services itself is a problem. And we have to find a way, given the constraints of our practice, wherever it is, the practice is, we have to find a way to enlarge the scope of what we're doing and to bring into it a psychosocial treatment that really can have meaning for the child and family.
Thanks, Dr. Dalton. I'm Marcus Wallace, also known as Marcus Lawless. I'm Chief Medical Officer for AmeriGroup, and I had the managed care section of our talk. And, you know, a lot of the themes, actually, we heard from Dr. Dunham and Dr. Dalton already, so I'm not going to repeat those specifically. But the primary things that came out, especially around identification, were around provider and parent toolkits, where we can really talk about, you know, educating providers on specific criteria, clinical practice guidelines, and screening tools, where the 5 managed Medicaid plans, in addition to commercial and Medicare, will hopefully come to a consensus and agree on some type of standardized toolkit that we can bring out across the state to all providers, in addition to parents. In terms of treatment, you know, some things that came up as themes were telemedicine, so increased access to care, so trying to promote that. Also provider directories, so PCPs and providers know where to refer members to, and that's kind of information that we can get in working with Magellan going forward. We also talked about getting the teachers to do, you know, possibly incentivized by payment for their screenings as well, or rating forms, excuse me, not screenings. We talked about the possibility of a clinical pre-auth form for newly diagnosed kids under age 6. I'm sure there would be a lot of work that we'd have to do before we came to a consensus on that, but that's something else in addition to educating the providers with some type of letter that DHH has already done around ADHD and appropriate prescribing patterns. So I think a lot of good things came out of our brainstorming session that are actionable. We didn't get really to focus much time on how we can support the families, which I think we can do that going forward, but I think we have a good nidus for, you know, going forward.
Thank you. So we've got the provider group, the behavioral health group, and then I was working with the educators, which included nurses, social workers, psychologists, teachers, and some family members. And we had a big group, and we wanted to speak as one voice and work together. So we actually worked together on these 3 topics of screening, assessment, treatment, and supporting families in the community of the social service system. And it was interesting to me that a lot of the solutions, there were some people with gray hair like myself, were saying, we used to do that. We have a policy for that. If we only could do it in a way that was more fundable so that we had staff to actually follow through with the policy and procedure, we'd be in a better position. So one of the suggestions that came out of this, especially with the 504 and some of the other programs like response to intervention, was we need to dust off some of the programs that the state used to fund and re-up those programs and really start to communicate with the legislature that they really need to refund some of this stuff so we can get to these kids more quickly and the staff actually have the time to do it. Differentiating between what a nurse does, what a social worker or psychologist does, what a teacher does, and what a family member does and what a prescriber does, their scope of practice, scope of influence in that continuum of care that a kid and a family will receive. That training on each one of their scope of practice and what they should be doing in that pathway of care that a child moves through was also identified. So training was a really big part of it. How can we train staff? There were some suggestions around mandatory teacher in-service around screening and assessment for behavioral health issues, including ADHD. Really good suggestion from a family member saying, you know, we have, as family members, have some of the biggest reason to get trained and to actually follow through with doing some stuff at home because we're the ones that are working with the kid all day long when they're at home. So training us to be trainers and supporting other family members is really the way to go, which I thought was a really good idea. Movement towards regionalizing and looking at the different regions and looking what the different needs are of the regions, whether they be rural, urban, and then getting the regions to meet together and then meet with the state. There was somebody who had mentioned, you know, hey, you know, we used to meet, the 504 folk, we used to meet on a regular basis as a region and then meet with a state entity to talk about what's going on, what our needs are, and we should start doing that again. Fidelity to practice and monitoring fidelity and using data to inform the regions of how they're doing as far as, you know, treating people with ADHD was also a suggestion. And having a behavioral health task force, which the legislature we have now, was something that they really wanted to see continue and to really grow some teeth and be able to actually follow through with some of these solutions that have been brought up, so that this isn't a flash in the pan event that we're having here, that this actually has to follow through and some teeth to it. Did I miss anything? I kind of tried to. Oh, training universities, both the undergraduate and graduate level, so making sure that the teachers that are training know how to do screening for behavioral health and substance use conditions, including ADHD, that is part of their role and that these new students actually see it as that when they come into the classroom, so that they really see this as part of their role. And how to, you know, balance as a teacher. How do you balance between, you know, the standard curriculum, or what do they call the standard core that is required now, and then also do behavioral health stuff on the side? How do you actually balance all that out in your role, which gets into the scope of practice, the scope of work piece? Because we've got a lot of disciplines working with each other through silos. And how do we develop kind of that continuum of care, that communication continuum, so that prescribers are talking with teachers and teachers are talking with families? It was I got a little sense that there is disconnect between prescribers and the school systems, and that there's not a lot of talking going on back and forth on a regular basis that's really substantive. So that was something that kind of came out too, as far as how do we develop these avenues of communication. So with that, I will open the floor before we do our final assignment. Any reflections on that? I want to make sure if there's any great ideas in any of the groups that are hanging out there, that we'd be able to send them out there, get them up on the wall. Or are you guys just completely exhausted? A lot of tired faces. That's good. That's a good sign. When folks are tired, you're not sleeping. So you're awake but tired. Yes?
Do you have a K-12 education representative?
That was one issue that came up, was do we have the Department of Education on the task force and talking with, or is it not K-12?
Yeah, someone who can represent K-12 education.
Someone who can, K-12 education, meaning what? Educators, so not graduate trainers or something. Okay. Is there somebody on the task force?
Part of the idea about today was to recruit folks.
Oh, what a nice segue.
Expanding membership of the task force. It's not internal, and we're expanding it. And part of opening the discussion today is making sure we get key folks joining the task force starting tomorrow.
So we have there an open invitation. Again, you are leaders because you showed up. Some of you are leaders because you call back and you are very persistent and you keep at this. We want squeaky wheels. We want people in the room who have something to contribute, who are willing to do a little extra work to really move this process along, to support the task force, to sign up for it. And I think there's a lot of people, at least there were a lot in my group, that I saw as people that had enough passion and leadership to actually pull that off. So if you're interested, do they talk with you, Kristen? Yeah, and just or sign up at the front desk or talk with any of us, just grab us. We will be communicating with everybody who registered. So both you on the internet and folks here, you will be getting updates on where we are with the task force. There will be a report. When does the report go out?
So the report is due to the legislature February 1st of 2015, and I was also going to point out that on our evaluations that you find in your packets, at the very bottom, we ask if you want to still be receiving communication from us and updates on what's going on with the task force, or if you want to let us know that you're interested in being more involved, you can write that there and leave that for us so that we know who wants to kind of move with us going forward.
Great. So does everybody have a card? And folks on the internet, you don't have a card, but you can certainly get one by doing what I'm about to describe and send it in an email to one of the task force members. We'd be happy to send you out a postcard. The idea behind this postcard is this. We often go to meetings like this, or we might go to an in-service day or a conference, and you meet cool people, you have lunch with them, you really connect, right? You might even get their business card. And then you commit to yourself when you're driving home, that was such a cool thing, I'm going to do this or that, or I'm going to follow up with that person. And then everything gets in the way, including your family, your life, your job, and you kind of forget, right? This is our call to action postcard. I was calling them kind of our leadership action postcards. Put down, we're going to give you a couple minutes, put down 3 things you're going to do as a result of this day. And I'm not going to give you suggestions because that's what will end up on the postcard. 3 things that you can do following today to move this process forward. Simple things that you could do today or tomorrow within the next couple days, not big, huge things, but actual behaviors, things you can do to move the message of the task force forward to improve the screening, access, treatment, and support of families and kids who are dealing with ADHD forward. And then you've got to put your address on it, because what we're going to do is we're going to mail it to you in 3 months. So this is going to show up in your mailbox in 3 months, and you can look and see if you were actually able to pull it off or not. All right? We'll give you just a few minutes to do that, and then we're going to wrap up. For everyone on the internet, everyone is writing diligently to their future self. Still got about a quarter of the room with their heads down. I'll give you another minute or 2. I think we got most of the heads up. All right. So here's the process. You're just going to leave those on the table. You can flip them up so the nice faces are up. Leave those on the table, and then we will mail those out to you in the next 3 months or so. So you'll be seeing those in your mailbox. Just some closing comments. There's an evaluation in your packet. If you want to receive the report, if you want to be put on a listserv, or you're going to receive more information, make sure you get your address, your email address on the evaluation. There's a separate form for CEUs. Remember, good old CEUs, people who want them. You're going to have to turn in a separate form for that. And the parking pass, if you want your parking validated, and if you haven't done that already, you've got to fill out a form out front on that. So I want to just thank everyone for coming. Thank our speakers from CDC, from all the programs, from Lane. We got a hand up in the back of the room. Do you want to stand up and say something? So, yeah, so we can send out all the presentations electronically, and it'll be posted on the website also. So it'll be posted on the website. We won't send those to you by your email. So be looking on the website for that. Want to thank you all for your time. This has been very impressive. And give yourself a hand. That's very appropriate. Drive safely.